It was an excellent video. I think today is a great day to start with, and we are going to start with all about blood. And I would request Secretary to take over and introduce our President, Dynamic President, Dr. Nilima Bhambre, madam. Dr. Hemant, is there? Are you there?
Yes, very much, Dr. Rajendra.
Yes.
Good morning, friends. A nice Sunday morning, and this is the second in the series of vision of our President, Dr. Nilima Vaidya Bhambre. When she took over as a president, she was very passionate and enthusiastic about bringing awareness in the medical fraternity about the organ donation. So we had one session, and now this is second. All that we learned before was about organ donation, majority after death, but now it is what you can do during your lifetime and do it many times. The easiest to donate, and God has not given that sort of a factory still to produce or procure blood, and this is what we are going to learn today. And I welcome our President, Dr. Nilima Vaidya Bhambre. She is MBBS, MD, DGO, DNB LLB President for this year. She had been Secretary twice of our association, Vice President HPI, Vice President KMA, founder member of Mumbai Dhadkan, Secretary being doctors, and member of a medical legal committee, FOXY. Welcome, Dr. Nilima Vaidya Bhambre.
Thank you so much, Hemant. And let me tell you all that we have already completed 1/3 of our year, 4 months already down the line, 8 more months remaining, and lots of work to be done. We are working on all fronts as much as possible. Let me also praise you of the wonderful Doctors' Day that we had. And let me thank all of you, because the auditorium was full, though it was a ticketed event, and none of the doctors were the participants, but we all came in large numbers and made that event a very big success. We launched 3 programs on that day. One was the tree plantation, and each and every member of AMC, we shall be planting 1 tree in your name on your birthday, and you shall get a tree certificate. So you have to frame this tree certificate and put up in your consulting so that you can inspire others. Another program that we launched on that day was the organ donation. I'm extremely passionate about it. And I always carry my organ donation card with me so that in case of any eventuality, anything happens, all my near dear ones, whoever I go out with, whoever knows me, knows that I want to donate all my organs. So that is something which we want to do, because once you're dead, you cannot tell anyone that you want to donate your organs. So all your relations, your near and dear ones need to know that you ardently want to donate organs, because that is one way of keeping yourself and your thoughts and your memories also alive, and helping somebody else. Everybody now has an established thing that the soul is the one, which gets transferred from body to body. So even in your next birth, whatever organs you may have donated in this birth, please rest assured that you will get all your organs and the fresh organs back, because it is a fetus which becomes a big human being. So do not worry, God is great and He gives all the organs back to you again. So please donate and register yourself as a donor and put that certificate also. We've designed a beautiful certificate for all of you to put up in your consulting room. So you should be leading by example. Our entire managing committee has registered for the organ donation. So I'm so proud of my committee, who is wanting to do things from the front. And the third thing that we launched was about the AMC clinics. We want to establish AMC as a brand, but not as a commercial brand. We want to establish AMC as as a body, as a strong body rather, who wants to do something for the poor patients. And that is the concept of the AMC clinics, where we want you all to register on our website, choose a day when you want to do these free camps for the people who are poor. Please understand that this is only and only for the poor people, and this way you can have a camp in your own hospital. Suburban is partnering us with in these camps so that they will come out with beautiful packages for the day of the camp. Suburban is also giving concessions to all the AMC members for all their blood investigations that you want to do. So please make use of this opportunity so that your hospital is able to cater to the poor. You get a good name in the society. Automatically, people start talking about your hospital and about your good deeds, and this is a way of improving your image. On the 14th of June, the World Blood Donation Day, we launched our blood donation camps. We have already collected more than 1,000 bottles of blood till now. So in one third of the year, we've already done 1,000 bottles, and by the end of this year, we hope to collect as many as possible. We would love you all to have these blood donation camps, and that is why I thought that today is a good day for all of us to understand more and all about blood. Hemant, I request you to take over. Thank you very, very, very much. And I hope you really find this session as interesting as our organ donation webinar, which was very, very, very widely appreciated. And I got so many messages at the end of the seminar saying that, Nilima, fantastic job done. We had today's speakers are also fabulous. So I hope you all listen to it very patiently. Please put your MMC registration numbers. The moment you join, you have to attend the full session if you want the MMC credit points. If you leave halfway, we have the MMC observer over here. So your attendance is going to be marked. So see to it that you all are present for the whole session, not just for the MMC credit points, but also for the knowledge. Thank you very much.
Thank you, President. Now I request Dr. Reena Wani, our program committee chairperson, who is a professor and unit head at HBT Medical College and R.N. Cooper Hospital, program committee chairperson for this year, core committee Foxy Violence Against Women Cell 2015 to 21, and there is a big list of introduction, 50 plus chapters in Foxy and other books, 75 publications in journals, 2 gold medal, 5 distinctions, 25 prizes, editor, co-editor of 14 books, author of 2 textbooks, a very popular unit head in Cooper, and in spite of all her assignments in so many organizations and at Cooper Hospital, she is doing a fabulous job for Association of Medical Consultants this year as a program committee chairperson. Welcome, Dr. Reena Wani.
Thank you very much. And it's my pleasure and privilege to be here with all of you today in this wonderful webinar all about blood. You know, Dr. Nilima said so beautifully, lead by example. And here I would like to say Dr. celebrates birthday by blood every year. And this year also for the blood donation, he conducted a wonderful program at Thakur College and got many other people to do it. So what, friends, we are trying to do is just increase awareness, and that we all should again spread the word. They say charity begins at home. If we start doing these things ourselves, things are definitely going to change. And our convener, Dr. Rajendra Chauhan, has put across a wonderful program for all of you. We welcome you all, and we are very happy to have you participate with us. And our 2 MOCs, Dr. Rajendra Tiwari and Dr. Ashwini Kalyankar, are consultants themselves, but are working for this program with great passion. And we look forward to supporting our president in her vision of making AMC as a body and its members as the lead in helping ourselves and our patients to improve in awareness and actual action about various aspects of blood. And it's not just blood donation. We are having wonderful topics like stem cells, cord blood banking, everything will be covered. So please be there and enjoy the program. And thank you all of you for being here. Over to our dynamic convener now, Dr. Rajendra Chauhan, for further program, and I'll hand over to the MOCs and the convener for the rest of the program.
Thank you, madam. Thank you, Dr. Reena Vani, for such a nice talk. I also want to thank this moment to Dr. Hemant Dugar for starting and giving a good kick start, and our dynamic president, Dr. Nilima Bhambre, who had given a very nice talk now. Talking about blood, you all know that I am very much passionate about blood, and I joined AMC mainly due to blood. And then we did hundreds of thousands of bags were collected from AMC and which are given to the needy people. AMC has always been doing this every year and round the year. All the members do need blood, and all the members need blood round the year. But always we have seen one thing, that there is always shortage of blood. There is never ever that it is not there, but there is some distribution which is not going properly. Sometimes somewhere excess blood is there, but most of the time it is shortage every day. And then we have to cover that shortage, and we have to have an equal distribution. That's why SBTC always comes forward, and SBTC, State Blood Transfusion Council, they always want that blood should be uniformly distributed, but blood donation should be motivated. And for that, they have come out with a very good site, and that is SBTC site. If you go on SBTC site or another site, I will tell you, that is e-Rakta Kosh. These two sites are there. You will get daily update of blood, which blood is available where, and the contact number and everything. So any person, any doctor, anywhere in Mumbai or anywhere in Maharashtra, if they require blood, so and there is a shortage, you can immediately get from there. You can get the donors list, you can get the blood bank, you can get everything on that, and it is dynamic. It is day to day, up to date. If people don't update, if the blood bank doesn't update that, then that blood bank will be penalized. So we get and perfect that in SBTC site and e-Rakta Kosh site. So please, everybody keep that thing in mind. And second thing is about blood. If we all member, when we need blood, we tell the relatives of blood leke aao. But instead of that, if we try to motivate कि आप लोग blood donate करो, आप लोग की देखो, लोगों को बोलो, if we try to motivate that, we can do much more. This is a message which I wanted to give to everybody, and that's why I thought of Dr. Nilima Bhambre, who was so much passionate that during the COVID time, when there was not possible to donate blood in Bombay, but she regularly donates, and she wanted to donate. She came all the way from there to Palghar, and she donated blood over here. So I am really thankful that she is so much in blood donation, and definitely all the members have so much done for the blood, and I require that. I request that everybody should also start talking with the relative, not only to bring the blood, but also to motivate them, because doctor's word are the final word, and that has taken them by the relative very positively. Only eligible donors should be there. The eligibility is extended from 60 to 65 now. So now it is from 18 to 65. And definitely, if all the members think, and if their family member come forward, there will be a big help to the society. With these words, I want to thank you very much, and all the panelists who have joined us, and they have given their time, and all the team AMC to keep faith on me for this program. I need to do many more programs. I will be very thankful if they allow me. And with these few words, I request our MOCs, Dr. Rajendra Tiwari and Dr. Ashwini Kalyankar, to take over and introduce and first to start with Dr. Rajendra Tiwari. Thank you.
Thank you, Dr. Rajendra. You have explained the blood banking related nitty-gritties. Your passion for blood bank is well known to everybody. In a lucid language, you have explained all the nitty-gritties related to the blood banking. Thank you. At the outset, I thank Dr. Nilima Bhambre, Madam, AMC President, Secretary, PCC, and entire team for giving me this opportunity. There is a Sanskrit shloka which says that Vidvatam cha napatam cha naiva tulya kadachana swadeshah pujyate raja vidvana sarvatra pujyate. It means a king and intellect, they cannot be compared, because a king is worshipped, may be worshipped in his own territory, but the intellect is worshipped throughout the world. So saying that, now we have a galaxy of such intellectual people today to guide us all about not only blood, but as Reena Vani Madam said, everybody, thalassemia, everything, thalassemia, blood transfusion related queries, and stem cell, about wide diaspora of topic is there, and galaxy of intellectuals are there to guide today. So I think this session is going to be very interesting. Now, many of us conduct blood donation camps. Here, Rajendra sir is conducting. We are also conducting in IMA and all various IMC also conducts here in Dahanu this year. AMC conducted. So there are a lot of questions from the donors. कि मैं ब्लड दे सकता हूँ क्या, 2 महीने पहले दिया था, मैंने वैक्सीन ली है, अभी दे सकता हूँ क्या. So many of the such complex questions are not, we are also not able to answer sometimes being in different faculty. So now today we have among us expert Dr. Ruhi Mehra. She is going to speak on the topic blood donation updates. Blood donation updates, who can and who can't donate. She has a very bright academic career. She is MBBS and MD in IHBD, that is blood transfusion medicine, and also she has got a diploma in transfusion medicine. She is at present working as a consultant in the transfusion medicine at Lilavati Hospital and Research Center, Mumbai. She has various honors, achievements, and awards at her disposal. During the entire 4 years of MBBS, she got gold medals. Not only that, she was awarded Best Student Award in 2013 during her academic curriculum. She got first prize in hands-on training conducted on the human leukocytic antigen workshop at Apollo Hospital, New Delhi in 2018. She got, not only that, she got Junior Investigator Award at THG in 2019. A poster competition was held in a conference ISTM wherein she got first prize on the poster in cellular therapy. She got third prize in a Cascade 2021 event, which was a 1-month training program, and at the end of the training, there was an exam. So in that exam, she got third prize. She is authorized NABL, National Accreditation Board of Laboratory signatory, as well as she is signatory for transfusion medicine related faculties. Her special areas of interest are immunohematology, transplant immunology, quality management, donor recruitment and retention. Now I'll invite Dr. Ruhi Mehra to please enlighten us on the topic blood donation updates. Thank you.
Good morning, all. Thank you very much for the invitation. I'll just start sharing my screen. Is it visible?
Yes, thank you.
And am I audible?
Yeah.
Yes.
Okay, thank you so much. Good morning, everyone. At the outset, I would like to thank the Association of Mumbai Consultants for giving me this opportunity to speak in today's webinar. My topic for today is who can and who cannot donate blood. I have outlined my talk in the following headings. First, I'll be telling what is the importance of setting up a donor criteria. And then we'll go into the new donor selection criteria, which was released in March 2020, the evidence behind the changes which have been done. And finally, I have a take-home message for all with the conclusion from this talk today. Now, coming to the importance of setting up a donor criteria, as we all know that a donor selection criteria becomes the first crucial step as a pillar of blood safety, because it is important method of reducing those infections against which a lab modality for testing hasn't been developed yet. So it is a preventive measure against the emerging infections for which we cannot do any testing currently. Even the World Health Organization has certain recommendations on which each nation has to establish their system for blood donor selection guidelines, which has to be based on epidemiological and scientific evidence. And wherever the evidence is limited, it has to be based on the best practices available. So the donor selection criteria has evolved over the period of time as and when new knowledge and new threats have emerged. But the basic core remains the same, that it has to be sensitive to identify who cannot donate. It has to be specific to avoid the deferral of eligible donors, and it has to be universal so that everyone agrees and implements it. Because with the blood center lies the dual responsibility of protecting the donors against any adverse donor reaction, as well as protecting the recipients against any adverse transfusion reaction. With this, the Ministry of Health and Family Welfare released this notification, that is the GSR 166E, on 11th March 2020, in which they updated the donor selection guidelines, and it is now referred to as the Drugs and Cosmetics Second Amendment from 2020. In this updated guidelines, the age available for donation for blood donors has been extended from 18 to 65 years if the person is a regular donor. But for first time donors, it has been kept up to 60 years. And for all our apheresis donors, it has been kept to 18 to 60 years. Now, the rationale behind keeping this age limits is that the lower age limit is in concordance with the national legal requirements for consent. There have been various studies which have concluded that younger donors in the age group of 16 to 17 years, they usually have a higher incidence of donation related complication, and hence the 18 years cutoff was decided, as well because there are increased iron requirements in adolescents during their pubertal birth growth. And the upper age limit was set as there are concerns regarding the increased incidence of cardiovascular disease with age. Also, there was a risk that there might be increased adverse reactions in our elderly donors. But there have been studies which were conducted and they showed that if a person is a regular donor, then they can donate till 65 years of age with minimal or no adverse donor reactions occurring to them. But if the person is a first time donor, then the 60 years cutoff was decided. The weight criteria in respect to the volume collected has been kept the same, as it is in accordance with the DGHS guidelines, which allows us to collect 8 ml blood per kg. So the upper limit followed in India is 450 ml of blood that can be collected. The evidence behind this is that any low body weight or low blood volume, they have been shown to be independent predictors for vasovagal reactions occurring in the donors. Coming to the interval between donation, now this has been updated for our female donors to 14 months. And this is because it has been seen that every 450 ml of blood donation removes approximately 200 to 250 milligrams of heme iron. Our female donors already have found to have low storage iron reserves. They have a higher daily requirement due to the ongoing menstruations. And it was found that the women of the childbearing age, they bore the brunt of donation-induced iron deficiency anemia. Hence, it was decided that to protect our female donors, the interval was increased to 4 months. Similarly, for our platelet donors, the upper limit remains the same, that is 24 times a year they can donate. But with studies, it was found that the regular platelet donors show a decrease in the levels of hemoglobin, hematocrit, as well as the red cell count. Hence, it was decided that after platelet donation, they can donate after 28 days. And similarly, vice versa, if after blood, they want to go in for a platelet donation. Coming to the blood pressure, if the donor has a controlled hypertension with or without medication, and provided their drug or the dosage hasn't been altered in the last 28 days, then they are eligible to donate. Now, the argument against allowing them for hypertension against deferral of hypertension was that hypertension could be due to many other reasons like donor anxiety, white coat hypertension, or there could be a recording error. Hence, there were studies conducted which found that even if the donor had a high BP, there wasn't found of any evidence of increased risk of donor reactions occurring in them. Also, there was no evidence found of any harm to recipients from donors who are taking antihypertensive medications when their blood was given to them. Hence, it was decided that donors with controlled BP are now allowed to donate blood. The hemoglobin cutoff is maintained at the same, that is 12.5 grams per DL, as it prevents the selection of anemic individuals and it provides good quality blood with adequate and consistent hemoglobin content. The meal criteria also remains the same, that the donor shouldn't be fasting so that their blood sugar levels are maintained. The last meal should be within 4 hours so that they don't have any episodes of nausea post-donation, and there shouldn't be any signs of alcohol intoxication. For our protection of our donors, the donors who are an air crew member or a long distance vehicle driver, they are advised to donate at least 24 hours prior to their next shift, as any delayed vasovagal reactions which may occur can put the donors or others as risk. Or if the donor is a shift worker, then they are advised to get adequate sleep of at least 5 to 6 hours before they come in for donation. Donors having any history of any high risk behavior, any history of travel to any geographical areas which are endemic for certain diseases which are not routinely screened for, they are deferred from donation. The donor skin has to be checked for any skin diseases or any puncture of scars which might indicate of them being a professional donor or an addiction of self-injected narcotics. Coming to the physiological conditions in women, If a female has delivered recently, she has to be deferred for a period of 12 months or for the entire period during which the lactation is ongoing. That is because the average woman needs about 350 to 500 milligrams of iron to maintain her iron balance during pregnancy, and hence the female donors are deferred to allow for the recovery of their iron stores. The surgical guidelines have been a bit updated. Like if the donor has undergone any major or minor surgery, then the deferral criteria has been increased to 12 and 6 months respectively. And this is to allow the individual's full recovery, restoration of their iron stores, resolution of any bacterial infection, or to detect any infections if acquired. Even for the dental procedures, the guideline has been extended to 6 months, as there have been evidence which have shown that dental procedures may lead to high tissue trauma, which causes a bacteremia effect. And these bacteria get lodged in sites such as liver and continue to exert detrimental effect on the host by inducing high levels of circulating acute phase proteins. The donors have to be permanently deferred if they have any history of cardiovascular diseases, neurological diseases like convulsions, schizophrenia. Dementia are deferred because of their inability to give a reliable medical history, multiple sclerosis because of the progressive nature of the condition, and uncertainty regarding the etiology. If our donors are having diabetes and if it is well in control with oral medications, then they are allowed to donate if there has been no change in the drug or the dose in the last 1 month. But if they are requiring insulin injections to maintain their sugar levels, then they have to be permanently deferred due to the concerns regarding diabetes related complications, increased risk of hepatitis and other infections if safe injection practices cannot be assured. Similarly, donors with thyroid disorders like thyrotoxicosis, Graves' disease, malignant thyroid tumors, or other endocrine disorders have to be permanently deferred. As we all know, any history of hepatitis B or hepatitis C infection, the donor is permanently deferred. But the procedures which put the donor at risk of these infections like tattooing, acupuncture, or body piercing, the donation interval has now been increased to 12 months for it. Any history of sexually transmitted diseases, the donor has to be permanently deferred as it is indicative of a high risk sexual behavior which can be associated with HIV transmission. The minor illnesses like cough, cold, they have to be deferred until the symptoms subside or till the donor is febrile. But any history of asthmatic attacks or on steroids for prevention of asthmatic attacks, they have to be permanently deferred. For infectious diseases, the deferral criteria is calculated based on the incubation period of the disease. For those diseases where the incubation period is known, they are deferred for twice the length of the incubation period. For them which the incubation period is unknown, the deferral is arbitrarily kept at 28 days. And following any acute infection, the donor has to be deferred for 2 weeks from the cessation of symptoms till when they are considered to be no longer infectious. For tuberculosis, the deferral period has decreased now to 2 years after recovery from the illness and completion of the treatment course. For acute infections like cystitis, UTI, the deferral has been now kept for 2 weeks. For any acid reflux disease, the donor can be accepted, but donors having stomach or duodenal ulcers have to be permanently deferred. Similarly, if a donor has history of diarrhea with fever, then they have to be deferred for 2 weeks from the last dose of medication. And that is because the gram-negative bacterium causing the enteritis, they are multiplying at 4 degrees at which the blood is stored, and thus this low-grade bacteremia can lead to fatal post-transfusion sepsis and toxic shock in the recipients. Donors have to be permanently deferred if they have any autoimmune disorders, polycythemia, bleeding disorders because of the excessive risk of bruising at the venipuncture site, or if they have any history of red cell enzyme deficiencies because of the reduced lifespan and red cell deformities, and the hemolysis may be precipitated in the recipients who receive their blood if they ingest those particular medications. For vaccinations, non-live vaccines, the deferral is kept at 14 days, live vaccines for 28 days, and for immunoglobulins at 1 year. For medication, the deferral is decided based on the underlying condition for which the medication is given, the pharmacokinetic properties of the medicine, as well as it is believed that the plasma concentration, if it is less than 10% of the therapeutic level, then the medication is most likely to be unharmful for the donor, for the recipient receiving the blood. That is why for medicines like retinoids, the deferral is kept for 1 month, because if they are given in the first trimester to a pregnant female, then can be teratogenic for the child. Similarly, other medicines given for BPH treatment also have to be given a deferral period from 1 to 6 months. Medicines like vitamins, oral contraceptives, the donor can donate. If the donor is taking aspirin, then the deferral of 3 days has to be followed if the blood is to be used for platelet preparation, since it irreversibly inhibits the platelet aggregation. For antibiotics, the deferral has now been increased to 2 weeks after the last dose. Recipients of organ, stem cell, or tissue transplants have to be permanently deferred, since it indicates serious underlying condition and as a precaution against possible transmission of other diseases. Donors who have had history of fainting episodes twice after donation have to be permanently deferred, and residents of other countries are accepted to donate in India only if they have a 3 years continuous stay over here. With the evidence of the COVID pandemic, the National Blood Transfusion Council released these interim guidelines in June 2020, in which the guidelines stated that a 28 days deferral had to be followed for any confirmed cases of COVID or close contacts of confirmed cases, and a 14 days deferral is being followed after the person receives COVID vaccination. After seeing the donation criteria, it has to be borne in mind that in the past, the donation criteria was considered like a dogma and it was never subjected to systematic study. The efforts are to define a rational evidence-based approach to eliminate the unnecessary deferral without improving safety, and the future relies on hemovigilance to monitor the effectiveness of intervention and to minimize the risk of blood donors. As today is the era of evidence-based medicines, and we know that the donation criteria has to maintain the fine balance between safety for our blood donors and recipients, as well as to maintain sufficient stock, as it is rightly said that blood cannot be generated in the lab. It has a human source. Only those who donate, then only the patient can receive blood. So we have to maintain a fine balance between the sufficiency and the safety of blood which is available. With this, I would just like to answer the one last question, that whether we should go ahead for donation, with a few figures. That the annual demand of blood units in Mumbai is approximately 3 lakh units per annum. The total population of Mumbai is approx 120 lakhs. If after meeting all this eligibility criteria, we find that 50% of the people are eligible to donate, and out of them, even if 10% decide to donate at least once a year, that would lead to 3 lakh units being collected every year. Then why should there be a shortage of blood in Mumbai? Because if we all donate at least once a year, if we all encourage our patients, our family, our friends, our relatives to go ahead and donate, then our stocks would ever be full and our patients would ever require it as and when they need it. These are my references for today, and thank you for your patient listening.
Thank you, Dr. Ruhi. It was a nice talk. Many of us are now aware how to select and reject blood donor in the camp due to your lucid presentation. Now our next speaker is Dr. Abhay Bhave. Friends, injudicious use of blood and components can cause disasters. Anything in excess is poison, it is said popularly. To guide us on judicious use of transfusions and guidelines related to the transfusion, there is an expert speaker, Dr. Abhay Bhave, amongst us. Dr. Abhay is MD from Sion Hospital, Mumbai. He is a fellow of hematology in Christian Medical College, Vellore, Tamil Nadu, India, as well as Royal College of Pathologists of Australia. He is currently working as a consultant hematologist in Mumbai. He is a recipient of Dr. B.R. Ramasubramaniam Award from Indian Medical Association for Academics in 2016 and 17. He has various other prizes as well as honors at his disposal. He has conducted anemia, thalassemia detection camps. He has made awareness to the patients regarding bleeding management, DVT awareness, etc. He is a sub-editor of hematology in the Indian Practitioners Journal. His advisory, he's on the advisory board of JAPI, that is Association of Physicians of India. He's a section editor of the Journal of Obstetrics and Gynecology also. He's a council member for marrow donor. He's a council member for the DVT guidelines of India as well as ICMR guidelines for myoplastic disorders. He has presented papers in various national and international conferences as well as published in various journals. Now, I'll invite Dr. Bhave to start his presentation.
Thank you very much, Dr. Tiwari, for the introduction. I will now share my screen. And I'm hoping I'm audible and my slide is visible. So at the outset, I want to thank Dr. Nilima Bhamre, Dr. Hemant Durgad, Dr. Reena Wani, and Dr. Chavan for the opportunity to discuss a very important topic in this forum of the Association of Medical Consultants, very aptly named and titled as All About Blood. I thank Dr. Ruhi Mehra for a beautiful presentation, which has made my life easier. So if you were to see a judicious nature of presentation of donation of blood, or use of blood, I'm going to show you some common case scenarios. So you have a gentleman who's 58 years of age, admitted for hernia repair, and his hemoglobin is 7. He is given whole blood transfusion and the surgery has gone very well. My thinking of injudicious transfusion over here is, why was he transfused in the first place? It should have been avoided. We should have found out the underlying cause. He may have just had simple iron deficiency or B12 deficiency. It could have been treated. If it was not urgent, we should have delayed the surgery. And why whole blood? We are componenting blood today to see that we give the right component to the right patient. Why whole blood? We should give up this practice. You'll have a patient who'll come to you, a young female, say, who's got low platelets, she's got petty-K, she's not actively bleeding from anywhere, but she's got platelets showing 10,000. Her dengue and all the tests have done, it has come back as dengue as positive. In this situation, I have the advantage of seeing the slides. These are reactive lymphocytes, and these usually occur with viral infections. They are not malignant cells. Usually, platelets stay because the fever goes off. I confirm the smear findings, and I do this to these patients. If they're not bleeding, then just treat the underlying cause. We should not indiscriminately use steroids. I'm seeing a lot of steroids being used in patients of thrombocythemia to bring up the platelets. We might nurses in between. However, if the had no fever with low platelet count, it would be ITP. Again, we don't give platelets even if the platelet count is 10. We get patients of platelet count 0. And as long as they're not bleeding, we don't give them platelets because their platelets are being destroyed. The given platelets also will be destroyed. So no transfusion unless there's bleeding. However, the same patient of thrombocytopenia has cells like these over here. These are called schistocytes. These augur poorly. So if it's an unconscious patient in the ICU, it might be TTP. They need plasmapheresis, not platelet transfusion. If they are bleeding, they're in DIC. They need all components of blood. If she might be in HELP or preeclampsia. She needs to be delivered as soon as possible, not to be given as platelet transfusion unless she's bleeding. And with this renal failure, this could be hemolytic uremic syndrome. So thrombocytopenia, front runner for a pathophysiology, which may vary depending upon the clinical picture, and hence transfusion should be avoided. So treat the underlying cause. This child was playing, hit hard on his knee, had a hematoma in the knee, and he had a family history of bleeding tendency. Now the hematoma, knee jerk, most people will put in a needle. Please don't aspirate because this child has had a trauma-related hematoma of the knee joint. With a bleeding history in the family, please remember it could be a factor deficiency like 8 or 9. Do the appropriate test, identify the factor, replace the factor. Why I'm saying don't aspirate is because sometimes by aspiration, you might further increase the bleeding. And here, there's no point in giving whole blood transfusion. You actually need to identify which factor is deficient and give the factor, not transfusions. If you've got a 32-year-old female who is delivered normally, but then for some reason she's had significant amounts of bleed, developed hypotension, and now going to hypothermia, you know that this is most likely a PPH. Especially you can predict it if the fibrinogen level was less than 200 in the patient at the time of delivery. So there's a predictor or a precursor. You could have prevented that PPH, but if you had not done fibrinogen, the patient gone to PPH, you have no choice but now to give transfusions of blood. And we have a different protocol over here. After 4 to 6 units of blood have been given, this patient will probably go into what is called as transfusion protocol. And the patient will have to be given not cells, but as packed cells continue, the bleeding continues, we'll have to other components of blood to see that she does not go into dilutional. What about a patient who is 75 years old, needs gallbladder surgery, but she's on aspirin and clopidogrel? Now, it's an urgent surgery. The risk of bleeding will always be, because as Dr. Mehra said, aspirin affects platelet aggregation. So you can give transfusions and get on with it. But clopidogrel inhibits the ability of the platelets to cause clots with the endothelium and between themselves. And therefore, transfusions don't help patients who are on clopidogrel. Over here, if it's urgent surgery, we take a high-risk consent and give transfusions at the time of surgery and post-operatively. We use tranexamic acid to help the wound healing, and we give DDAVP to improve the ability of the platelets to adhere to the endothelium. However, if the surgery is not urgent, then instead of giving transfusions, we can defer the transfusion, stop aspirin for 3 days, clopidogrel for 5 to 7 days, if it is allowed by the neurologist or the cardiologist, whoever has started the dual antiplatelets, and then go ahead with surgery. What if we could not stop these drugs and the surgery is not urgent? Then we have Cangrelor as an IV medication, which is an antiplatelet, which can be used as a bridge when you stop the dual antiplatelets. Cangrelor can be given as IV, and it can be stopped a few hours before surgery, and the risk of bleeding is less. And therefore, the risk of clotting in the interim time when you stop the antiplatelet is also less. So we win both ways. What if you've got an 85-year-old man who was drowsy and found on the floor of his house? He's got a CT brain which shows a subdural hematoma. Now, he could have been on warfarin, and if he needs surgery, we'll need to give either recombinant factor 7 or prothrombin complex concentrate. Or if we can't afford both, or the hospital doesn't have either, then fresh frozen plasma to bring down that INR back to normal. However, if he's on dabigatran or the newer agents like rivaroxaban, dabigatran or rivaroxaban, plasma will not help. So that is injudicious. Dabigatran has idarucizumab, which is a reversal agent. Apixaban, rivaroxaban have andaxinate, but it's not available in our country. Idarucizumab is available in our country and easily available within 1 hour once it is needed. So in this situation where you don't have a reversal agent, you could still use recombinant factor 7A or PCC in order to reduce the effect of these DOACs, or just wait out about 12 to 14 hours, the effect goes off, and then we can get on with the surgical event. So the whole rationale for using of blood component is providing the right product in the right quantity for the right patient. I think that's extremely important in our scenario. It bridges the gap between the demand and supply of precious limited blood or blood components or blood products. Dr. Mehra told you that we are not donating enough for whatever reasons, so we have to conserve whatever we have got. An important component of transfusion is also understanding the underlying etiology or the clinical assessment of the patient prior to transfusion. Because if a patient has a normal platelet count and the patient is bleeding on antiplatelets, obviously you will end up giving platelet transfusion to these patients. Don't be fooled by numbers. Look at the assessment, look at the clinical picture and the pathophysiology. So you should assess not only the quantity, but also the quality of the blood prior to giving transfusions. Unfortunately, many times as hematologists, when we get patients coming to us, they've already been admitted, possibly in another setup, given transfusions, sometimes along with steroids, and then sent to us. In this situation, injudicious use of components may have prevented us from diagnosing conditions like leukemias, G6PD deficiencies, paroxysmal nocturnal hematuria or hemoglobinuria, hemolysis, and certain hemoglobinopathies, which would have been important for us to make the diagnosis and decide on the treatment. They become difficult once you already transfuse the patient. Thankfully, today, a large amount, almost all our blood, which is whole blood, is converted into components. And therefore, we are able to use the right component for the right patient at the right time. And that's how judicious transfusions should take place. And all major hospitals in the city of Mumbai and all the other cities in our country do have the ability to make components. You'll notice over here that the components that are kept at different temperatures. For example, packed cells are kept at 4 degrees, the platelets are kept at 22 degrees, and the FFP and cryo are kept at minus 30 degrees centigrade. Which means you can't use whole blood indiscriminately, because whole blood may have red cells, but the platelets and the plasma are destroyed, and you're just giving them nuisance value neutrophils and platelets, which cause alloimmunization. So be very careful and judicious when you're giving transfusions. Now, what do the guidelines teach us? That don't go by numbers alone as a deciding factor for transfusion, as we saw in the hernia patient of 7 grams, unnecessarily transfused. Be aware of the risks of transfusion. So don't be very loose about it. Transfuse only if there's clinical benefit. Justify transfusion and need on paper, because there can be a look back. Tomorrow, if a patient gets HIV, hepatitis B, or hepatitis C, the same patient will turn to you and say, you're the doctor, you gave me blood. You should have said no. I'm a lay person. I asked for the blood, but you should have said no. Now I'm saddled with an infection which will affect my well-being and quality of life and my longevity. So we have to be very careful and justify why we gave on paper, because there'll always be a look back. And whenever we decide to give blood, let's monitor the transfusion well. And don't forget, in today's world, you must take a written consent prior to giving any transfusion. Those days of giving blood without telling the patient are gone. You have to tell them beforehand. Even for the surgeons and anesthetists who are going to give blood in theater, they have to take consent prior. Wherever it's possible, we identify a reason. Let's replace that reason and see that the hemoglobin comes up prior to surgery so that we can avoid transfusion. But there are some situations where transfusion is inevitable. For example, cardiac compromise, elderly patients who are breathless and cardiac failure, rapid drop in hemoglobin like G6PD hemolysis, autoimmune hemolysis, or a DIC which has gone into a spent phase and the patient is bleeding, or there's active blood loss as part of trauma. Normally, in any lecture or discussion, complications are showed at the end. I don't want to do that. I want to show you to you much earlier, because look at the number of reactions and complications that can take with blood transfusion. So I plead to you, be very judicious in your transfusion, follow guidelines so that you'll not have a problem. The one which is most abused is platelet. No one knows what is the level at which platelet transfusion should be given. The situation sometimes might demand platelet transfusion to be given, but they can be associated with acute lung injury. It's called transfusion-related acute lung injury, TRALI, which might put you into an ICU. We don't know how many times in a day to give. Some people give once in a day, some people give twice in a day. We don't know. It depends upon the clinical situation. You might need it more than once in a day. We give RDP or SDP. All our hematology patients who need recurrent transfusion get SDP, that is single donor platelet, which is equivalent to 6 bags of random platelets. And random platelets can be made from each donor, as I've shown you in the earlier slide, from the blood bank. RDP is a blood bank property. SDP is a patient's property. So we can use it over a period of 5 days. RDP can be given to anyone who's in need and we cannot reserve it. But one thing we must remember, RDP exposes you to more number of people. Therefore, alloimmunization is higher, especially in our hematology patient need recurrent transfusion. That same alloimmunization and transfusion risk become lesser when we use SDP. So if you're using it recurrently, prefer to use SDP. I don't give prophylactic and platelet transfusion even to patients who have got low platelets unless there is a reason to give or there is ongoing bleeding. And there are lots of data, stops, spots, and tops, which has been done to find out whether we should give prophylactic platelets. No one has said that it should be given. There are alternatives to platelet transfusion, such as immunoglobulin or in ITP, steroids and immunosuppressive agents, to bring up these platelets so that you don't have to give platelet transfusion. But in these situations, you have no choice but to give platelet transfusion. You have to be judicious to use platelets in this situation. Whole blood is also abused. It should be used mainly in trauma. It can be given as reconstituted blood, that is packed cells where the anticoagulant has been removed, and then we add the FFP to that for intrauterine transfusion. The same can be used for exchange transfusion when the neonate is born. Fresh as possible. Blood is between 2 and 7 days. Generally, we give off blood for those chronic patients who need recurrent transfusion as fresh blood. Otherwise, up to the age of the blood that is kept in the blood bank, you can use blood without a problem. But one whole blood which I want to use in this forum to kind of propagate is autologous transfusion. I think it's not used enough. And I plead with all those people who are listening to this just now, please go for autologous transfusion, where you use the patient's own blood provided the hemoglobin is above 11 and the hematocrit is more than 33. We can take up to 10 ml per kilogram body weight for these patients. They could be, even collected in the theater by the anesthetist in a blood bag and given back to the patient after the surgery is over. No cross match, it's safe blood. There's no danger of transmitted infection. So the blood loss is not to be too much. Why expose the patient to blood unless to someone else's blood, and therefore collect his or her own blood beforehand? So autologous transfusion is a unique approach as it helps to avoid the use of allogeneic blood. In terms of red cells, I think that's another abused component. Please don't give blood if the hemoglobin is more than 10. If it is indicated if it's less than 7, but not mandatory, and it is essential if it is less than 5. So between 5 and 7, the question is why not give blood? Between 7 and 10, the question is why give blood? So constantly we are questioning ourselves. However, if someone is symptomatic, please give blood. There's no doubt about that. Don't be fooled by the fact that wound healing is promoted by transfusions. Even a hemoglobin of 6 or PCV is adequate in order to allow the wounds to heal and avoid whole blood as far as possible. ICU patients, a place where All components are abused, unfortunately, because the patient is perceived to be critical. We do lots of blood collections per day. That's why the hemoglobin is bound to drop. In such patients, don't transfuse in a non-IHD patient unless it goes to 7. And for an IHD patient, the new criteria is 7.5. Fresh frozen plasma at 15 to 30 ml can be used for various things such as factor replacement, warfarin reversal, DIC coagulopathy, or patient going for a surgery who's got a coagulopathy, bypass surgery, or patients who've got thrombotic thrombocytopenic purpura who needs plasmapheresis. Cryoprecipitate is the one which is not being used very often, and it is also used in the indications which are shown here. It is used as 1 to 3 bags per kilogram body weight. It's available in the blood bank. It is made as a component. Unfortunately, not used enough. But its utility also has come down over a period of time, unless we are looking at dilutional coagulopathy with massive transfusion or patients in DIC. TEG is something which I can tell my anesthetist friends who might be there on board along with the surgeons that you can do a TEG, thromboelastogram, in the theater when the patient is bleeding to know which component is lacking. Is the patient bleeding because of platelets, because of a coagulopathy, or because of fibrinolysis? And accordingly, you can give either cryoprecipitate, FFP, or platelet transfusion. So it will be very judicious transfusion by you in the theater. I see some practical problems as I'm coming to the end of my discussion. I've seen sometimes blood kept in the fridge, in the, not the freezer compartment, the one below that. Is kept over there till the patient is given blood. Platelets are sometimes kept over there. Remember, platelets were on a shaker in the blood bank. If you just keep them somewhere, they are going to die. You are not going to give them viable platelets. You're just going to give them sludge. Blood should not be kept in a fridge. It should be used as soon as it comes into the ward, provided it is thawed. You should not put the FFP and cryo into a water bath where the hub is in the water. That causes contamination, because once you open the hub and put in the IV set, the infection is going to go through it into the patient. Long periods of axial transfusion, sometimes I read notes saying to give slowly, blood slowly. What does slowly mean? No one knows what slowly means. And even the writing doctor does not know what is meant by slowly. He's just scared to give blood. Blood transfusion should get over anywhere between 2 to 3 hours. If there's a cardiac compromise, 4 hours. Please do not exceed that. Do not unnecessarily use steroids prior to transfusion, because genuinely if there's a transfusion reaction, you won't know till more blood has gone inside, which is more detrimental to you. Inadequate transfusions are situations where we give pediatric doses to adults. If you are giving blood, give wholeheartedly. Otherwise, don't give. Call an expert who will be able to guide you. And sometimes there are unnecessary transfusions. That means you had a surgery, you anticipated blood, you got blood and kept, and then now you're giving it because blood is brought to the hospital. If you don't give it, that blood will go waste and the patient's family will question, where is that blood? You don't want that to happen. You give blood unnecessarily. Please avoid these situations. There are some blood products rather than blood components which are available through the pharmacy on the shelf. And these can be used as replacements to bring up the deficient factor and make the patient proficient so that you don't have to use transfusion. Now that is judicious behavior. For example, you can give factor 8, factor 9, or you can give recombinant factor 7. You can give immunoglobulins to bring up the platelets. You can use fibrin glue during surgery so that your transfusion requirement is less, because your bleeds will be much lesser. And to prevent what I call this as a quick fix hematology, that if blood is less, give blood, platelets are less, give platelets indiscriminately, it is worth having a transfusion committee on board, which I don't think it has the power to veto, but it has the power to tell you that things, how things should be done. For example, in our hospital where I work, the cross-match to transfusion ratio was high in certain departments, which meant they would ask for cross-match, but they're not transfused. What we realized was that there were 2 or 3 days when the cross-match blood was kept reserved for certain patients. They were not being used, but the general population did not get it. So other patients in the hospital did not get because they had paid for this reserve. So we sent a letter around to all the departments and told them, please only cross-match those patients who genuinely need blood. Suddenly our blood inventory improved. Now there are guidelines from our National Blood Council and National Blood Committee, as old as from 2007 when it was put down, and earlier too. And it has got certain objectives which are similar to what I have described. We've got the British guidelines, which talk about right blood for right patient, right time and right place. And we've got from the US and Europe, several papers that have been published about hemoglobin, and you'll notice over here that most of the people would want to give blood only at 7, irrespective which society it is, across the group, surgical, medical, and gynecology and obstetrics, and for different situations that are there. So 7 is our cutoff from all papers. And this is based on several publications that have been done from authors from around the world for different situations, where clearly they have said, don't do injudicious transfusion, especially for packed cells. Probably they have the most abused is the packed cells. Keep the hemoglobin 7 and above before thinking of transfusion. So I'm going to share with you my Mann Ki Baat as my ending slide for this discussion on judicious transfusion. I think we have to have strategies to ensure rational use of blood components. So we should take a consent. And I thank AMC for organizing this clinical awareness program so that we can reach out to a larger audience to be able to tell them to use judicious blood transfusion so that the right patient gets therapy. We should set up a hospital transfusion committee. We should review our data of what's happening, the transfusion reactions, and everything should be reviewed. Importantly, the surgeons, anesthetists, the gynecologists and obstetricians, and the intensivists who allow patients to go for surgery should do what is called as a major surgical blood order schedule, MSBOS. That means you should confirm that the right amount of blood of the right blood group is available for the patient prior to going for surgery. It should happen that you operate and it turns out to be a rare or a negative group and you don't have the blood available. You could find yourself in trouble, and therefore be very careful that you have told the blood bank prior. If you've got a patient in your nursing home which needs such kind of surgery, I would strongly recommend transferring to a tertiary center which has a blood bank. So we can promote the right blood component in the right amount to the right patient at the right time. And I would say at the right place so that everything goes smooth and we don't end up in trouble. We should encourage autologous transfusion, which unfortunately is not happening in our city especially. We should have a good inventory of blood bank. I'm very happy to tell you, and Dr. Ruhi Mehra will also tell you that there is a federation of blood banks. So they talk to each other, they give each other data about what groups they have, and they can share if someone else needs that blood group. And the patient should be given blood only for valid consent. Valid indications. Please do not give transfusion just because the patient has got admitted, needs surgery, the family has taken a holiday so that one of them can be in the hospital and you have no choice but to get on with surgery. Don't let this happen. See that the indication is valid, because tomorrow if something happens with the transfusion, you are going to be questioned because the buck stops with you in terms of transfusion. So there are more discussions on filtration of blood and radiation of blood. I'm very happy to tell you that I can see on the list some very good speakers on this. My speaker following me is Dr. Atul Kulkarni, who will be speaking on components. So you'll get more information than me. Filtration of blood and its value will be told probably by him, and especially by Dr. Mamta Manglani, who will speak about thalassemia. She's one of the best I know. And in radiation of blood by the stem cell guys, they'll tell you. So conserve a limited source, and I thank you very much for your attention.
Thank you very much. Very nice presentation. I really liked it.
Thank you, sir.
Dr. Rajendra.
Yeah, Rajendra, with your permission, I would like to thank both Dr. Ruhi and Dr. Abhay. It was a wonderful discussion, very, very practical. And Abhay, your Mann Ki Baat, I think we should frame and put in all our clinics, because these are the key points which were there. And I hope we are going to have a recording of the webinar so that which can be shared with all our participants, because the take-home messages are so very important. I think I will also have to review my hospital practices immediately starting tomorrow, because certain important clinical pointers which you have given are applicable to each of us. And there are a lot of questions, but I think we are collecting the questions towards the end. So we hope that you will be there to take the questions at the end of the session. I again request all the participants to please type your questions into the chat box. And if you want a specific speaker to answer, you can direct the question. Otherwise, our MOCs will be doing a interactive session with all the speakers after all the presentations. Over to you, Rajendra.
Thank you, ma'am. Thanks, Dr. Abhay Bhave. It was an enlightening talk indeed. Now, the third speaker is Dr. Atul Kulkarni. He is the director and in charge of Jan Kalyan Blood Bank, Pune. He is MBBS and diploma in pathology as well as diploma in transfusion medicine. He is an auditor, internal auditor for a blood bank, NABL, and an internal auditor for hospital NABH, entry level NABH. He is a member of governing body and technical committee of SBTC, that is State Blood Transfusion Council of Maharashtra. He is a lead assessor for NABH accreditation, that is NABL accreditation for blood banks and NABH accreditation for the hospitals. His special area of interest is safety and quality in the blood transfusion services. Not only this, but he himself is a blood donor, and he has himself regularly he donates platelets to the needy. I invite Dr. Kulkarni to please elaborate on the blood components and bedside blood transfusion practices. Dr. Atul Kulkarni, over to you.
Very good morning to all of my friends and colleagues in Mumbai and all across Maharashtra. I must thank Association of Medical Consultants Mumbai for giving me opportunity in this CME. Special thank to Dr. today's convener, Dr. Rajendra Chauhan sir, for giving me the opportunity. It's really interesting to have a CME on blood and the persons who are working in blood banks. We are very much eager to discuss various topics related to blood components with the clinician, so that if there is any gap between the understanding on our side or with clinicians, it should be bridged. So it's a good opportunity to interact on the subject of blood component and bedside transfusion practice. As we all know, blood is life, and transfusion medicine is the science of saving lives. Previously, the transfusion medicine or blood centers, they are focusing on lab side centric service, but now the scenario is changing and it is a clinically oriented discipline, and it is treated as a subspecialty to specialty. The scenario about blood transfusion, whenever we hear the terminology of blood transfusion, we come across this funny scene, but very emotional and impactful scene from Amar Akbar Anthony. Miles have changed. Actually, this is also not the true representative of blood donation and blood transfusion, but this is how we thought. And since the blood is collected and given to the patient, so we were in the era of whole blood previously. So just refresh, we will refresh our knowledge about the blood and blood components in this first part, which we are dealing with in day-to-day practice. Usually the blood, what in our terminology we call it as a whole blood, and now we all know that this whole blood concept is going on as but still in some clinicians' mind there are some questions, doubts about it. So I would like to emphasize few of the points related to whole blood. Please note that the platelets are not there in whole blood, as platelets are stored at 22 degrees Celsius and red cell is stored at whole blood is stored at 4 degrees Celsius. Also, whole blood doesn't contain clotting factors, labile coagulation factors, because to maintain this labile coagulation factor, minus 30 degrees Celsius temperature is required, and the blood, that is whole blood, is kept at 4 degrees Celsius. So in modern era, what if we want to discuss about indications, so we can safely say whole blood is used whenever the components are not available. I don't want to go in the disadvantages and contraindications, because this is an old generation product which rarely used today. At my center, since last 1 decade, we are using only components for the treating patients. So this is how the component therapy has evolved, and it's very useful. and it is possible because of the modern technology and the plasticizer, plastic bags. So it's possible there are two types of components separated from pheresis or whole blood components with the help of automated systems by Buffy code technique or a platelet-rich plasma methods. Previously, we just thought that there is a whole blood and packed cells or red cells, then plasma and platelet. But mind well, there are different plasma, blood and blood components that are available for clinician to treat the patient appropriately. So in red cell, there are different aspects, red cell suspension, leuko-reduced red cell, irradiated, washed red cell. For platelets also, pheresis platelet, random platelet, leukodepleted platelet, pooled platelet, irradiated platelets. For WBC, granulocyte and lymphocyte concentrate. And apart from this, there are plasma components, that is fresh frozen plasma, single donor plasma, cryoprecipitate, cryo-poor plasma, and plasma derivatives also. They are provided by the pharmaceutical companies, that is albumin, factor VIII, concentrate, immunoglobulins, and fibrinogen. So in this first part, we will be discussing the commonly used components and that are most commonly asked from the blood center. So red cell concentrate or PCB, what we usually call, is separated from whole blood. Either the whole blood collection is 350 or 450 ml. So depending on that, it is collected, and usually whenever we say that blood is required, that is equivalent to red cell, that we are is synonymous that red cells are required nowadays. So replacement of red cells in anemic patients use with crystalloids and colloids. Usually this is the volume is around 200 ml plus or minus 100 ml depending upon the additive solutions and what is used. And usually what we have observed that usually with 1 unit of transfusion, 1 gram, the hemoglobin is raised by 1 gram. So hematocrit usually is 50 to 70%. So if you add additive solutions to this red cell concentrate, then it is called as red cell suspension, which has the hematocrit value is a bit lower, that is 55 to 65%. So more higher flow rates, better flow rates are observed with the help of red cell suspension. And another important point is that expiry is extended from 35 days to 42 days. Second most important component is fresh frozen plasma. What we say usually that this is the most irrationally used product now, and so awareness need to be there with the product and its indications also. So this fresh frozen plasma is separated from whole blood and it's frozen quickly after separation. Usually 6 hours of collection, the product is frozen to minus 30 degrees Celsius, and then the clotting factors are there along with the labile and the stable coagulation factor. Both are preserved and it is kept at minus 30 degrees Celsius, and you can keep it for 1 year. Whenever you want to transfuse, then you have to thaw the plasma, liquefy it at 37 degrees Celsius, and then you can use it for the patient. So the important point is that after liquefaction or thawing, it should be utilized immediately within 6 hours, or if not, then you have to refrigerate it at 2 to 6 degrees Celsius, and then you can use it in 12 hours. Usually the replacement fluid, replacement of multiple coagulation factor deficiency, liver diseases, and all this, it is used most commonly. Unit of issue, usually single unit contain 200 to 300 ml of plasma, depending upon it is separated from 350 ml whole blood or 450 ml whole blood. As you know, it contains albumin protein parts, so allergic reactions are not uncommon with fresh frozen plasma, especially with rapid transfusion, and severe life-threatening anaphylactic reactions can occur. Also, important what we have observed is TRALI. It's also with one of the dreadful complication after fresh frozen plasma transfusion. So initial dose is usually 15 ml per kg body weight. The administration is ABO compatible plasma need to be given. So for A patient, A group plasma, B patient, B group plasma, O patient, O group plasma. In this, the AB plasma is used universally for any group that we will discuss in the latter part. So compatibility testing is not required, but group specific plasma need to be given, and after liquefaction, it should be transfused rapidly within 6 hours. Another component which is prepared from fresh frozen plasma by controlled thawing is a cryoprecipitate. As name says, it's a precipitate of fibrinogen and clotting factors. Whenever you are going to liquefy the fresh frozen plasma in a controlled temperature, it usually contains about half of the factor 8 and fibrinogen in the donated unit. Unit of issue is usually supplied as a single donor pack or pack of 6. So usually 6 to 8 units are transfused at a time for an adult patient. Infection risk is similar to other blood and blood component. Storage same as plasma up to 1 year at -30°C. So indications usually as an alternate to factor 8 concentrate, also as a source of fibrinogen, example in DIC. Administration, please note, since the volume is very small, 20-30 ml, so there is no need to have a ABO group specific cryoprecipitate. You can very well give any group cryo to any patient. After thawing, infuse as soon as possible through a standard blood transfusion set and must be infused within 6 hours after thawing. So third, again, next important product is the platelet concentrate, and as the cases of dengue are increasing, there is an increased demand, and we are always in short of this product, RDP or single donor SDP. But mind well, as previously discussed, all the blood and blood components should be used very judiciously. So usually 50 to 60 ml is the volume, and plasma is the medium, and each unit it contains 45 into 10⁻⁹ platelets in a unit. Usually it is stored at 22°C and can be stored up to 5 days. So please note the temperature, because we have found many times the nursing staff or RMOs are not aware, and they will keep this RDP or SDP in a refrigerator, which makes the platelets inactive, and then if you transfuse this product, then it will be of useless. So please note the storage temperature is very crucial as far as platelet is considered. Infection risk is same, rather it is more. The bacterial contamination risk is more, as the temperature, storage temperature is 22°C. So we are very cautious about storage of platelets. So usually, as you know, thrombocytopenia, and prophylactically also preventing bleeding due to thrombocytopenia, it is required, but it should be used judiciously. We have already gone through a session of rational use and judicious use. So not generally indicated for prophylaxis of bleeding in surgical patients unless known to have a significant preoperative platelet deficiency. Not indicated with idiopathic autoimmune thrombocytopenic purpura, TTP, untreated DIC, etc. So dosage usually 1 unit per 10 kg body weight. So usually 4 to 6 units are given for an adult patient. We have also come across, and sometimes 1 or 2 units are asked for by the clinician. So especially while giving the transfusing the patient. If it is really required, then give a full dose. Please note that ABO compatible platelets are preferred, but you can very well give ABO incompatible platelets also, because the plasma volume is just 50 ml. So it won't make any problem as far as platelet transfusion is considered. Absolutely must check for RH, if the mother is RH negative and red cell contaminated unit is there, that is the only thing where you should check for ABO compatibility, RH compatibility in females if it is a red cell contaminated unit. So another way of collecting platelets is a pheresis technique. So with the pheresis, you can get the platelets. It's a tailor-made product, you can say, and has a very numerous advantage that you are going to reduce the donor exposure, because 1 unit of SDP will be having 3 into 10 raised to 11 platelets, usually 40 to 50,000. Count is increased after transfusion of 1 unit. So you are going to reduce the number of exposure. It's a full and effective transfusion dose, higher quality product. Fewer products as leukocytes will be reduced during the process, and ability to match to the patient, so HLA matching can be done. Let us have some case scenarios because during day-to-day practice we come across numerous scenarios. So let's discuss some of the bedside problems that we face. Usually for obstetricians, PPH, we are very cautious about it. Patient's group was A positive. As a practice of the hospital, they have reserved 1 or 2 units. But now more number of units are required, and only 2 units are available with the blood center, and they have offered for O positive red cells as the patient was A positive. So should we accept or not? So just refresh our knowledge. Landsteiner has laid down about the antigens and corresponding to what type of antibodies are there. So usually the group is A, B antibodies are there in the serum. If red cell are the group is B, then A antibodies are available in the plasma, and if the group is AB, then no antibodies. That means anti-A and anti-B antibodies are absent. So by this checking, you can understand for red cells, if donors red cells are O, then you can safely transfuse to A, B, and AB group patients. So don't waste time. Accept O red cells in case of shortage of A, B, and AB if the transfusion is required. So group-specific red cells are preferred, but ABO compatible red cells can be given, as we have discussed. So this is a just chart for your ready reference. This is how you can select appropriate group. So just as a nutshell, you can remember O in ABO category, O is a red cells can be given safely, and O negative will be the best choice if RH group is not known, and vice versa for plasma. AB will be the best choice. Another case, 86-year male, HbA 4.5, blood group was A negative, needs 3 transfusion. As we all know, the RH negative groups are very rare, and what to do, the blood center have advice for A positive. So please note that RH positive or negative is based on the presence or absence of B antigen on the red cells, and like ABO antibody, which are naturally occurring, the RH antibodies are not naturally occurring. So in RH negative person, we don't find anti-D antibodies. So in case of emergency, we can safely transfuse RH B positive cells. We are more worried about only in a childbearing age group where there can be a sensitization and the subsequent pregnancies will be at risk. So if in this case it was a male patient, so there was no risk about RH, about pregnancy. Elderly patient, so in case of emergency, with a proper documentation and consent, you can safely transfuse D positive, means RH positive blood to the patient. So similarly, there a common scenario with obstetric patient, mother sample is asked for at the time of transfusion, cross-matching. So it's very important because antibodies, IgG type of antibodies can be transmitted through placenta into the baby's blood. And so hence it's very important to check antibodies that are transmitted in the baby. So mother and baby's samples are required for cross-matching. So please note this point. Another area, 28 years female, history of previous transfusion, needs red cell transfusion again. Antibody screening of the patient is positive, but cross-match is compatible. So it's a good scenario that atypical antibodies were present, but the unit is compatible. So atypical antibodies are developed because of other blood group systems that are there on the red cells, and some of them are significant and can cause delayed hemolytic reactions also. So we are worried about them. But since in this case cross-match was compatible, so there is no need to worry much. But if it is incompatible, then you have to either identify the typical antibody or cross-match numerous units to find out the compatible unit. And depending upon the nature of antibody that is present, warm or cold type of antibody, then you can select the appropriate unit. What we have commonly observed that in case of cold AIHA, the best possible or least incompatible unit, it is transfused and it is very well tolerated by the patient. But in warm AIHA, it's a Herculean task for the patient to find out a compatible unit. So with these some of the problem day-to-day occurring cases, I would like to emphasize some of the bedside tricky situation that we face and why we are worried about all these things, why there are numerous protocols that we are trying to follow for transfusion is because of the risk of getting blood transfusion reaction to the patient. And there are different blood transfusion reactions that are there. It can be immune mediated or non-immune mediated, acute or chronic, hemolytic, febrile, allergic, anaphylactic. So all kind of reactions and all these things are there. And hence we are worried about the reactions. And some of the, so it's a responsibility from clinical side also that whenever you are going to transfuse any product, you should get a consent, informed consent should be taken from the patient. And in case of special situations, like I have mentioned, incompatible unit or alternate unit, alternate group unit, you should take a special informed consent. So please note that before transfusion, some point need to be re-emphasized. Do not warm the blood by putting the blood bag directly into unmonitored water bath. Usually the transfusion is well tolerated. There is no need of warmer. Only in case of large volume or where the massive transfusion takes place, then and then warmers are required and that can be used. Do not add any medication to the bag. Use blood transfusion set for transfusion, and the transfusion should be started within 30 minutes of issue of blood unit. So pre-transfusion medication, avoid them. Routine use of acetylphenophan may mask the fever. So antihistaminics rarely required and should be used. Infusion fluids, only isotonic saline is recommended to be used with blood component. Do not prime the administration state with dextrose because it's incompatible, or RL calcium chelation can take place. So dextrose will cause hemolysis of red cells, and calcium in the ringer lactate will cause clot formation. So they are incompatible. Before administering blood completely, flush all the incompatible fluids and drugs, preferably, and change the state. So in a nutshell, this is the chart showing red cells, fresh frozen plasma, cryo, do's and don'ts. So please remember that this knowledge need to be percolated to the RMOs, nursing staff. It's a joint venture. The blood center and the clinical team in the hospital, if they join hands and adopt the standard operating procedures of the transfusion, know what and when to transfuse, then we will definitely achieve our goal of safe blood transfusion. It's a journey, lot more to go. Let us make the journey safe. Thanks a lot. Thanks a lot again.
Thanks, Dr. Bhave. Thank you very much. It was a eye-opening presentation by you. Now I'll request Dr. Ashwini Kalyankar, madam, to please continue the further session with thanks to all the president, PCC, and secretary.
I thank Dr. Rajendra Tiwari, excellently conducted, and please, Ashwini, take.
Thank you, sir. Thank you.
Thank you.
Thank you.
I would like to just say a small word about Dr. Rajendra Tiwari. He has been associated with me since Nair days, and he's a very enthusiastic and now a senior consultant who has been working in many ways. And Ashwini is actually a laparoscopic surgeon, breaking the barriers that people used to think only the boys can do laparoscopy. So both of them are, and we appreciate their help and inputs today. I would like to thank Dr. Atul, who has given the lovely inputs from Jan Kalyan Blood Bank, and I think a lot of take-home messages. Again, I feel we should summarize a few of the slides which are important, and maybe we'll come out with a little handbook. Dr. Rajendra Chauhan has always been doing work on blood donation in Palghar, but in fact, as a convener, I think maybe we can come out with a small booklet or a handbook with the key points from each slide, because everyone may not have time to go through the entire webinar, and for those members who have missed it, perhaps we will put up in one of our issues of GRASP. And of course, the next speaker is very dear to me, Dr. Mamta Manglani. I have worked with her in Bombay Municipal Corporation, and it's an honor, madam, to have you in our program. So I'll hand over to our next MOC, Dr. Ashwini, for carrying the program forward. Thank you.
Thank you, ma'am. Thank you, ma'am.
Reena,
Yes,
we have to request all the speakers to remain till end because the question answer session is at the end.
Yes, we have actually requested all the speakers to be available because the MOCs are collecting. We already have more than a dozen questions related to various aspects of the talks. But in the interest of time and to give justice to all the speakers, since we have a time-bound frame, we would like to keep the questions at the end. So based on how much time we have, we can go forward. So requesting all the speakers to please be there till the end. Yes, over to you, Dr. Ashwini.
Thank you so much, Reena, madam, for such a wonderful and lovely words in Sunday morning. I'm feeling so blessed. Thank you so much, AMC, under the leadership of dynamic Dr. Nilima, madam. Thank you both the Rajendra sirs for picking me up as an out-of-box MOC for an out-of-box webinar going on. And so many participants, almost 323, 350 people have joined. So many wonderful comments we are getting on the chat box. Stay with us. So let's move ahead with a wonderful speaker Comprehensive Care in Thalassemia by Dr. Mamta Manglani Madam. Mamta Madam is a Director, MCGM, Comprehensive Thalassemia Care. She is former Professor in Pediatrics and Division of Hematology, Oncology, LTMG Hospital Science. Madam is a life member of Indian Academy of Pediatrics, Mumbai branch of IAP, Pediatric Hematology, Oncology chapter of IAP, Mumbai Hematology Group, Indian Society of Hematology and Transfusion Medicine. Welcome, Madam. Over to you.
Thank you. Thank you, Dr. Ashwini, for the lovely introduction. And at the outset, let me thank AMC for organizing All About Blood webinar, which is so useful because I think even I'm enjoying the talks. I would like to specifically thank Dr. Nilima Bhamre, Dr. Dugard, Dr. Reena Vani, who has said such lovely words, and I reciprocate the same to her. And of course, last but not the least, Dr. Rajendra Chauhan, who is a convener and has been in communication with me. Of course, the other members who have been working hard, like Dr. Rajendra Tiwari and Ashwini. With this, I'll share my screen so we can go ahead with the talk. Is my screen seen?
Yes, madam.
Yeah, thank you. So I'm putting it in slideshow. It's taking a while. Yeah. So here we go. As we all know, thalassemia is not a one-time management disease, and it requires comprehensive care. And this is a center where we offer comprehensive thalassemia care. Of course, we also look after children with cancers and other blood disorders over here. And it's a Mumbai Municipal Corporation Hospital. We also do bone marrow transplants in this center. We have an 8-bedded unit. I have, due to want of time, I have not put the video of the center. Normally, I show the video so that people get aware. So I'll straight go to thalassemia related management. We all know beta thalassemia is the most prevalent syndrome in the country. Though alpha thalassemia prevalence as far as carrier state is concerned is much higher. It's 12% compared to 3 to 4% of beta thalassemia trait. But as a disease, we see more of beta thalassemia homozygous. As we all know, beta thalassemia is represented on 2 genes, whereas alpha is on 4 genes, and hence the difference in the prevalence. I'll not go into details of those, but just to recapitulate what happens to a baby who's born with thalassemia homozygous, especially if they are transfusion-dependent thalassemia. They will be pale by 6 to 18 months of life, may have a small liver spleen. They start developing hemolytic faces, that is malar prominences, frontoparietal bossing, as you can see clearly in this baby, in this child, and huge liver spleen as they progress if they are not well managed. If they are, these are older pictures when we did not really know how to manage thalassemia way back in the 80s. But as chelation therapy became available and better management was offered to them, we don't see these type of scenarios any longer. So what is the treatment of thalassemia? Of course, there is transfusions, which is the mainstay of treatment, which is the lifeline for thalassemia patients. But with transfusions come many of the other complications, especially iron overload due to multiple transfusions, which are lifelong. And this leads to endocrinopathies, bone disease, etc. And there is a battery of things that happen in these children, including various endocrine organ involvement, cardiomyopathy, thrombosis, liver cirrhosis, splenomegaly, diabetes, arthropathy, etc. All this can be tackled by curative therapy too. And you need not go through these complications if one goes through hematopoietic stem cell transplantation, which is going to be the next talk by Dr. Shantanu, and I'm sure he'll elaborate along with other conditions about thalassemia too. Then there are some other experimental therapies. Future therapy, gene therapy is also a curative therapy. What are we doing today in thalassemia? Most of the times we are offering palliative care. And why do I say palliative care? Because some transfusion is given without understanding what should be the level of hemoglobin maintained at every time in a child. And some chelation therapy, because we are aware that there are some iron chelators available in the market. That's all that is being offered to children mostly. It is not all the time, but most of the times. There are very few centers which understand that there is need for comprehensive care in these children. And then there are even fewer centers offering curative therapy, especially the bone marrow transplant or the hematopoietic stem cell transplant. Gene therapy, of course, is not yet available to us. It is actually commercially available in Europe and US. However, it is going to cost $100 million per patient. And therefore, $1 million. So therefore, it is not feasible for our patients at present unless we have indigenous, and the research for that is going on in CMC Vellore. We are hoping in next 5 years, it should be possible to have indigenous gene therapy. So starting with comprehensive management, palliative should be avoided. No patient should just be given transfusion when they become symptomatic and tided over the crisis. That is palliation, which is not to be done. Instead, we must focus on comprehensive management of transfusion-dependent thalassemia. I'm not going to allude to non-transfusion dependent thalassemia because it's a different subject and a different topic. Since we are talking today all about blood, we'll talk of only transfusion-dependent thalassemia. So these are the components of management in comprehensive care. Packed red cell transfusions, managing complications arising out of them, diet management, which is a minor but important component, curative treatment, and future perspective, as well as gene therapy. And last but not the least, I'm going to touch upon prevention. So let's look at when you start transfusions, what you need to do in these children. We often forget to do these aspects. If a patient is likely future BMT patient or a transplant patient, he must have a CMV serology testing done. If preferably in infancy when he comes, it should be IgM, and in older children, IgG. Now, this testing will help us to know the status before transplanting this patient and the risk that he will have CMV reactivation post-transplant. And then the management strategies would be different for this patient. However, in our country, since 95% of population is CMV positive, it may not have a great impact in choosing donors in a patient who is positive. Who's negative. We will probably have a donor which is positive and then take care of that, or other way around. HIV, hepatitis A, B, C, and liver function tests should be performed before starting transfusions. Vaccinate for hepatitis B if they are negative for HBsAg and they do not have anti-HBs antibody levels in adequate amount, that is more than 10 units in them. Hepatitis A immunization is equally important because you're going to have this liver of these children getting targeted through various mechanisms, including the disease itself, iron overload, transfusions repeatedly, and therefore should be protected at least from a preventable infection so that he does not have to suffer double trouble. Ideally, we must do complete genotype of red cells before starting transfusion so that you can give a completely cross-matched red cell transfusion to these patients, which means that you would never risk a chance of alloimmunization. However, this is hardly practical in our country because no center, except for barring maybe a couple of centers which is doing complete genotype, most of the centers are only doing the ABO-RH typing and giving compatible blood according to that. Of course, if alloimmunization occurs in those patients, we do send for complete genotyping. So the type of transfusion that a patient deserves is group and type specific packed red cells with a hematocrit of 65 to, just a minute, I'll just get a pointer. Yeah. So with a hematocrit of 65 to 75%, completely matched, as I told you, red cells are preferable, genotype matching after genotype antigen typing, but this is not practical. So what we do is take red cells compatible by indirect antiglobulin tests to transfuse to these patients. They should not be more than 4 to 5 days old, preferably, but does not mean you cannot give, suppose the blood center does not have blood which is fresh, and you have a thalassemia who needs to be transfused because we want to maintain a good pre-transfusion hemoglobin. Then do not compromise. Maybe you go ahead and give, but as much as possible, avoid giving very old blood. Ideal leukodepleted red cells, which I will come to later on. Triple saline washing is only required in those who have recurrent allergic reactions despite leukodepleted red cells, not regularly. The rate and frequency should be kept as it is mentioned here, 15 to 20 ml per kg of packed red cells every 3 to 4 weeks, or shorter intervals also may be used. rate should not exceed more than 5 ml per kilo per hour. Now, this is where most of the clinicians make the errors, that they do not transfuse 15 to 20 ml. They give just 10 ml per kg, assuming that that's the rate at which the patient can tolerate. And the transfusion goes on so often for 6 hours, 8 hours, which is not ideal. Ideal is to give 15 to 20 ml over 3 to 4 hours at the rate of 5 ml per kg per hour. Only in those patients who already have a cardiac dysfunction, we must not exceed the rate of 2 ml per kg per hour. And pre-transfusion hemoglobin should be maintained between 9 and 10.5. So every time a patient comes and anywhere he's lying below 10, one should transfuse, but definitely below 9. If the patient is not maintaining hemoglobin, then you might have to give more frequent transfusions or increase the volume of transfusion. Mean hemoglobin should be 12 to 12.5 post-transfusion, but it should not exceed 15 grams per deciliter. But we do not advocate doing a post-transfusion hemoglobin, because that has to be performed 24 hours after the transfusion and not immediately post-transfusion, because that will give you a wrong reading. Now, this is the 16-bedded daycare transfusion unit at our Borivali Center, which is a very comfortable environment for the patients and parents both. So preferable to give in daycare centers treatment, so that they can meet their peers and they can exchange their problems and interact with each other. So they get a peer group support, the parents get support from other parents, and they learn how their children have gone through if they are older children and they are a new patient. So it helps sort of hand-holding for a new patient who enters into the center. Managing complications is the next aspect. Transfusion reactions, non-hemolytic febrile transfusion reactions are the common ones which we deal with. We'll first deal with that. So NHF-TRs can be taken care of if we use leukodepleted red cells. And how we can do the leukodepletion? The best is to do pre-storage using inline filters at the blood center level. It also prevents cytokine release and therefore does not allow any reactions to occur. Otherwise, if we do not have that facility, one can use post-storage bedside leukofilters, but these may have cytokine-related reactions. Now, there is a third method of doing laboratory leukofiltration, which is after the blood has been, when the blood is being issued from the blood center, one passes it through a leukocyte filter and puts it into another bag and then issues it to the clinician. However, that will not have any difference compared to post-storage, except that while you're giving the transfusion with the leukocyte filter, often the blood does not pass through easily because you're going to give at a fixed rate. You do not want to exceed the rate, whereas you can literally pass it through very quickly in the laboratory before issuing the blood. That's the only advantage. Now, the benefits of leukodepleted PRBCs, besides the fact that they reduce the NHF-TRs, is also it reduces the chances of CMV infection through blood and prevents HLA allosensitization. As we all know, the HLA is represented on the leukocytes, and therefore it will prevent the HLA antigen to cause the sensitization. Of course, if this is a good filtration. So therefore, when we do saline washing, we only deplete 85% of the leukocytes. But when we do the through the filters or pre-storage, we are reducing it at least to less than 5 into 10 raised to 6 leukocytes, which is ideal. Ideal would be even less than 1, but it's adequate to do below 5. So this is how we in our center use leukocyte filters for every patient. This is a double bag filter. There are single bag filters and there are double bag filters, and all of them get leukofiltered blood. What about irradiation? Is it a must to irradiate all these components that we are using in thalassaemic patients? It is preferable, especially in those who are eligible for hematopoietic stem cell transplantation, because it reduces again the HLA aluminization, which then translates into reduced graft versus host disease, which is one of the most dreaded complications we are anticipating in a patient who's undergoing bone marrow transplant. And again, it also helps to reduce CMV infections. Now, what does irradiation do differently from leukodepletion? It makes the leukocytes functionally paralyzed. So they cannot function. So they do not cause all the problems that they could cause, even if they are physically present. That is the difference between leukodepletion and irradiation. So peri-transplant, all our thalassemia patients will receive irradiated components, especially for at least 6 months to 1 year before and post-transplant till as long as they require transfusion, or at least for 1 year, 1 to 2 years post-transplant. What about the next complication? Besides the reactions, you have transfusion-transmitted infections. This audience has a lot of transfusion medicine consultants, and therefore it may not be relevant for them because they are much more literate in this aspect than I would be. However, I'll just touch upon for those who are non-transfusion medicine consultants. So how does one manage these transfusion-transmitted infections? Of course, conventionally, we are screening the blood bags using the anti-HIV, HBsAg, and anti-HCV screening by 4th generation ELISA test. The more important part is stringent donor selection. I often wonder as to whether are we doing enough to select a donor stringently in blood centers? Do we administer the elaborate questionnaire first of all? Would our donors who are voluntary donors admit to high-risk behaviors without being cross-questioned? Would they admit themselves in the questionnaire? These are the questions we have to address and make our population more aware that they must be honest and admit if they have a high-risk behavior, so that we do not end up giving transfusions to patients with infections. So stringent donor selection, I think, is more of a transfusion medicine and a blood center, but clinicians must also encourage their patients or relatives of patients not to bring in professional donors for donations to the blood center. Of course, we have today NAT testing, which can reduce the window period significantly, both for HIV and HCV, which are more important because hepatitis B, we are vaccinating and therefore we're not seeing that much infection. I have not put really the details of how much it reduces because of shortage of time. Alloimmunization is another issue causing increased requirement of transfusions. And we just heard Dr. Kulkarni tell us about which are the group systems which cause these clinically significant hemolysis if there are antibodies. So there are so many groups of blood, and complete genotype matched is not easy and practical. 30 blood group systems as per ISBT, out of which 9 blood group systems are clinically important, which I have listed here. And we need to find out if a patient is requiring more than required transfusion, more than previously required. We must check on hypersplenism, alloimmunization, and rule out alloimmunization. So just to denote a case here, 11.5-year-old girl who was taking regular transfusions was not maintaining adequate pre-transfusion hemoglobin, and therefore we had to look at her Coombs test, which was positive. We gave her steroids for 3 weeks. There was no response. We requested a complete RBC antibody panel, and it came out to be positive for anti-E, capital E, and we transfused her the cross-match blood for 2.5 years without the E, and she cleared the anti-E antibody. So we got the donors who were also E negative, and therefore she managed. And as you can see here, she became negative. No red cell antibodies were detected after 2.5 years. So it's not that difficult, but it is tedious, and one has to look into these aspects. We have seen alloimmunized children almost reaching the point of no return with 3 gram hemoglobin, 4 gram hemoglobin, which is something which is worrisome for us, as once they are so low and they're not maintaining, they may go into cardiac failure and may succumb to the disease for reasons which are manageable. Coming to iron overload, I'm not dwelling on immune dysregulation. This is not a major part, but of course it does affect the CD4, CD8, immunoglobulins as well. So we need to look at them and remember, if a patient becomes more predisposed to infections, keep in mind that multiple transfusions can lead to immune dysregulation, but I'm not dwelling on it as it is not a major aspect of management. Coming to iron overload, we all know all our patients in the past, thalassemia patients in the past, in the 80s, early 80s, late 80s, died at 12 to 15 years of age related to cardiac iron overload, since they were not getting their iron chelation therapy adequately or even at all, because it was expensive. There was only one injectable desferrioxamine available, which was therefore not possible to give. And this is the one which is to be tackled maximally And of course, there are other organs, liver, spleen, endocrine. It can lead to bone disease or skin pigmentation. So all of this has to be also looked at in a thalassemia patient. And how do we tackle this iron overload? First of all, how to assess iron overloads. There are many various tests that have come up in the decades that we have gone through, but ferritin has stood the test of time. However, ferritin being an acute phase reactant can really give you sometimes very wrong results. Very high ferritins without actual iron overload have been noted. I had a patient of HIV with MDR TB and who had a ferritin of 1,80,000. And everybody told me, ma'am, this patient should get IV Desferal because he's got a very severe iron overload. So I told them, I don't think this ferritin is really depicting iron overload. Let's look at his other parameters and look at infections, treat him adequately for those aspects, and repeat a ferritin after 2 to 3 months. And as we treated his MDR COX, we put him on second line antiretroviral therapy because he was resistant to first line. Within 3 months, his ferritin came down to 10,000. So that is the reason why ferritin should not be relied upon as a one single reading. Trends of ferritin do help, but better than ferritin is the liver and cardiac MRI, which correlates beautifully. The liver MRI correlates beautifully with liver iron estimation, and the cardiac MRI correlates beautifully with cardiac muscle biopsy related iron overload, which has been done in studies by Dudley Pendle et al. In 1990s, etc. So therefore, today we have a non-invasive MRI, which is T2 star weighted MRI, where we can look at iron overload in every child of thalassemia. Unfortunately, this is possible at 7 years onwards, and therefore early on we may not be able to make out. But then iron overload becomes more and more as age progresses, and managing iron overload is much more challenging after 7 to 10 years of age. So how do we manage? We have various drugs in our armamentarium. The one which I was talking, time-tested desferrioxamine. Unfortunately, it is to be given as injectable drug, subcutaneous pump, through the subcutaneous pump for 8 to 10 hours every day for 5 days a week, which is very difficult for any patient to comply lifelong, but there are patients who do comply. We then got deferriprone or Kelfer as a molecule, which was very good for the thalassemics to get something oral in place of desferrioxamine, and a cheaper drug, which then became the drug for thalassemia. However, soon we got a second drug, Deferasirox, and many brands of Deferasirox are today available. Today, Deferasirox is preferred over even Kelfer or deferriprone because this takes care of both cardiac and liver iron, whereas this takes care mainly of cardiac iron, though it also has some effect on liver. And Desferal has effect on liver iron more predominantly, but when given intravenously, it has good effect on cardiac iron. So these are the various chelators that can be used in these children, and knowing which one to use and what doses to use is important. Of course, we can use combination of chelators where we can combine the deferriprone Kelfer, which has good cardiac iron chelation, and Desferal, which has good liver iron chelation, or Deferasirox with Desferal. Both can be used. Both have been shown to be useful, and both oral drugs can now be combined and given to the patient if they are not responding well to one or the other eye. So I'm not again going to dwell much into this. A word about cardiac iron overload. As we see with the advancing times when chelation therapy became available, the deaths from other causes went down, but cardiac iron overload deaths increased in time because patients were not very compliant and did not get iron chelation done well for the cardiac iron overload. And other causes of deaths also went down because we started managing transfusions better. So that is why cardiac iron overload has to be tackled very astutely in these patients. The endocrine complications that we see, short stature, delayed puberty, hypothyroidism, hypoparathyroidism, diabetes mellitus, have to be monitored from time to time and have to be taken care of. So we start doing the thyroid function test and blood sugar random at 5 years onwards. A GTC can be done at 5 years onwards if you are suspecting in random blood sugar comes high. Look at calcium levels in your routine biochemistry, which is done at least every year once. If you feel there is a low calcium, look for hypoparathyroidism. And short stature to be monitored at least 10 years onwards. You must look at whether the patient is growing in height well, and delayed puberty for girls at 13 years if no menarche, for boys at 14 years if there is no secondary sexual characteristics, we need to investigate. So these are the monitoring we have to do. This was a 14-year-old boy of hemoglobin E thalassemia diagnosed at 4 years of age, taking inadequate transfusions, referred to us in 2017 when he was 12 years of age. We put him on a regular transfusion program after he failed hydroxyurea trial. His weight and height were both less than 3rd percentile, also not falling in the curve for mid-parental height. And his testing was done for growth hormone, which came positive. He received growth hormone and he responded well and he grew well. As you can see in the chart, his height has grown well and now he's following the mid-parental curve, or he's above the mid-parental curve. So this is how one can test and treat. Though they are expensive medications, there are donors who support and we manage to treat these children. Another girl I want to talk about, 32-year-old female, first by birth order, born of non-consanguineous marriage, Catholic by community, diagnosed at 6 months of age as hemoglobin E beta thalassemia. At 6 months to 13 years was apparently normal, not requiring transfusion, growing well. At 13 to 26 years, she was started on hydroxyurea, requiring transfusion every 6 to 12 monthly. And then she came at 27 years to us. Her problems were cytopenia due to hypersplenism, iron overload related osteoporosis and hypothyroidism, alloimmunization. And we gave her comprehensive care. She conceived naturally and delivered a healthy baby boy. This is the patient and the child she delivered. So there are stories which are very inspiring and fulfilling, and one should try to struggle and take these challenges, manage these patients. Coming to bone disease, osteoporosis, osteopenia are very common due to iron overload, and we need to manage them with physiotherapy, calcium, diet improvement, as well as giving them sometimes bisphosphonates. I'm not going in details of this too. Diet management, mainly you have to look at giving zinc if they are on Kelfa. Iron poor diet may be advocated, but as I always tell everybody, the iron from diet is a drop in the ocean, as they receive 250 milligrams of iron from every blood bag. And we absorb just 1 milligram of iron per day from our meals. And therefore, one should not be forcing them not to eat iron-related diet, but can advise tea and coffee with meals to retard the absorption. Also, if they are very fond of foods which are containing iron, just leave them alone. Doesn't matter much. You may try to tell them if they don't like and mother is forcing them, then you may not give foods rich in iron. So at best, comprehensive care will help to improve lifespan to 50 years. Comorbidities unrelated to thalassemia will unfold as they grow older, and quality of life may not be as good. And this is available to only less than 15 to 20% of thalassemics. So naturally, curative treatment should be considered. And I'm not going to dwell into details of this because Shantanu will be talking on this. So let me just go to, this is the first child ever transplanted at our Borivali Center in 2018. And he was a thalassemia homozygous, transfusion dependent. And you can see he's doing well. Of transfusions, of chelation therapy too now. Ferritins have come below 500 and he's celebrating his birthdays year after year without transfusions, without chelation. So transplant is a possibility in even a public sector hospital today at our center. And at Sion Hospital too, we had created a 1-bedded unit. So both these units created during my tenure have helped many children get cured. Future perspectives, there are many new drugs coming up. I'm not going into details, but this one, luspatercept, is right now being used regularly by some patients. An expensive drug, has some effect, if not completely takes away transfusions, but reduces the need for transfusion. Gene therapy, as I told you, will come sometime, maybe 5-6 years down the line. But if curative treatment is not feasible, patient doesn't have a matched donor, no matched unrelated donor, haplo is something which we are still not very comfortable with, and he's dependent on transfusions, chelation, needs to undergo so much monitoring, visit to hospital lifelong, cannot achieve full potential, undergoes significant psychological and emotional trauma, and lifespan may be compromised. There's a huge economic burden both on the family and the nation, and hence prevention is the way to go. So what do we do for prevention? There are two ways to find out whether I'm a carrier for thalassemia or not. Voluntary screening before marriage or before bearing first child, or after we have a child with thalassemia major. Because there is an ease of finding out carrier status in thalassemia, especially beta thalassemia, therefore, if knowing the unaffected carrier mother and father is not difficult at all by just doing the HbA2 analysis. And by that, we know that in each pregnancy, there is a chance of having 1 in 4 chance or 25% chance of having a affected child that is a homozygous child. So how do we go about? We do population education so that people are aware. Go ahead with mass screening to identify these thalassemia carrier couples, genetic counseling of at-risk couples, and prenatal diagnosis. So who should get screened? All healthy, normal people belonging to high-risk communities, desirous of beginning their family, all who have a relative with thalassemia major, and those in whom hemoglobin remains low despite iron therapy when it is a microcytic hypochromic anemia. So how does one screen? One first looks at the blood count where you would have low HB, maybe borderline low, 10, 11, 9, sometimes up to 8 and 7, and low indices with high RBC count and a normal RDW. And when you do the hemoglobin A2, it would be generally above 4%. In borderline A2, between 3.5 to 4, one must look at DNA mutation studies or a molecular workup is warranted. When two thalassemia minors get married or are planning to have a child together, there's a 25% chance in each pregnancy. This is the underlining thing. It is in each pregnancy. So if you have one thalassemia child, doesn't mean my next child will be normal. What can they do? Detect the thalassemia major in unborn fetus before it's too late for termination. So preferably in first trimester. So as soon as the woman misses a period and they both know that they are thalassemia minor, they must come for chorion villus sampling and take an appointment. We do it at our center. You all can refer patients to us. We would counsel them and we would take them up for the procedures. If they miss the bus up to 15 weeks, we can do amniocentesis. 18 to 20 weeks cord blood sampling, but this is a very tricky way to do it, and therefore we do not prefer to do it because the time taken is so long to get the molecular workup, about 2 weeks, that they may cross the time of termination. To end with take-home messages, the first and foremost, prevent the birth of a thalassemic child by doing this testing in masses and therefore counseling them not to have a child with thalassemia. If already born and diagnosed, treat them ideally, not half-heartedly, the way we have been doing in our country. Test the siblings and parents for HLA matching so that they can be potentially taken up for hematopoietic stem cell transplant as curative treatment. If siblings, parents don't match, then we can go for a matched unrelated donor. Now the registry has about 4 lakh donors, and we do get matches through that. It's fully matched donors, and it is becoming better and better. So one should try that too. Novel therapies may be offered in conjunction with ideal conventional treatment. Of course, wait for gene therapy for those who are not eligible and maintain them well while they are waiting. Because if they don't get maintained, they will not be eligible even for gene therapy when it is available and affordable. If you are planning your family now, this is directed at all participants and members who are attending this webinar. Test yourself and your spouse for thalassemia trait, whichever community you belong, because I have seen giants coming with thalassemia. I have seen those communities which were never mentioned in books or in articles also coming with a baby with thalassemia. Therefore, do not be over-enthusiastic to be confident about your status. Please test yourself and your spouse if you're planning your family. I think with this, I will just thank my team, because without team, I cannot do what I'm doing. They are the reason why I've reached where I've reached. Thank you everyone for a very patient hearing.
Thank
Thank
you
you,
so
madam. It was an excellent talk, madam. It was worth listening you. I was long waiting for that, and today was the day. And many things I need to improve, because I have 60 thalassemia children which I regularly send to you for that. And definitely it is going to help all this, not only this, but many other people, with many people looking this. Thank you very much for your kind guidance
Thank
and
you.
your support to the society.
Thank you, sir.
Ashwini madam.
Thank you so much, madam, for such a wonderful talk and making us easy to understand the thalassemia in a better way. Thank you so much. Let's move ahead with the second talk, which is Dr. Shantanu Sen. CD, please. Sir is a senior consultant and head of the Department of Pediatric Hematology, Oncology, and BMT Kokilaben Dhirubhai Ambani Hospital, Mumbai. Sir has a special interest in haploidentical transplants. Sir has fellowships at Royal Marsden's Hospital, London, and Great North Children's Hospital, Newcastle, UK. Sir is examiner for MRCPS examinations in India and UK, numerous national and international publications. Over to you, sir. Thank you so much. Sir, unmute yourself, please.
Thank you so much. Thank you so much for that very kind introduction. It's really a pleasure and a privilege to be following Madam Manglani. She's been somebody I've held in amazingly high regard. She's an amazing person. Kind of thinking what she has done, opening BMT units, not one, just two, out here in the government setting is an amazing achievement, Madam. I'm always your admirer. It's a pleasure to follow such amazing speakers, and I'm sure I may not be able to reach it, but let me try. So if I may share my screen. Just give me 1 second. Right, I'm in the full screen mode, hopefully.
Yes, sir.
Okay, right. Thank you so much, Association Medical Consultants, for getting me here and for me to speak about a topic which has been my passion for now more than 25 years, actually. I started getting interested in transplants sometime in 98, 99 when I started work in UK, and it's been a wonderful journey. So first question is, what really is a BMT? So, I mean, it's a procedure, it's a medical procedure that's known by many different names. We call it a bone marrow transplant. It's also now called a marrow and stem cell transplant, peripheral blood stem cell transplant. But possibly the most, let me just get a pointer. Possibly the most accurate term would be a hematopoietic stem cell transplant. The reason for that, what we are transplanting is the hematopoietic stem cells, which are found in the bone marrow. And these are the cells that would go on to develop further into each and every blood cell that we know. So from the hematopoietic stem cell, you get the lymphoid progenitor cells, from where you get the T cells, the B cells, the NK cells, and of course the beta cells will produce the plasma cells. And from the myeloid progenitor cells, we'll get the megakaryocytes leading on to platelets, our eosinophils, basophils, the RBCs or erythrocytes, and then the other cell lines. So basically what we are transplanting is the very core hematopoietic ancient stem cell that leads to each and every one of this cell. So which means that we can use this treatment to kind of treat and cure any diseases that affects any of these cell lines. And so which means that if I can rebuild these cells, I can treat the diseases. So if we have a problem with aplastic anemia, reticular dysgenesis, or Fanconi's, which basically has a problem with the stem cells, doing it will cure it. Similarly, if we have a severe combined immunodeficiency or a T or a B cell immunodeficient disease, that can be efficiently and very effectively treated with a BMT. We can think of the neutrophils if they are not being made, congenital neutropenia, or neutrophil function, which is the congenital granulomatous disease. Madam just now talked about red cells, so the hemoglobinopathies, which is thalassemia, sickle cell disease, or the platelet disorders. And then also the various enzymes that are made from the mature cells. So all our mucopolysaccharidosis and inborn errors of metabolism can be effectively treated with this form of treatment. So when starting, let's talk a little bit about where we started. Where did we have this journey? So this journey started almost more than a century ago when we discovered this new force called radiation and X-rays. And people started getting very interested in this new force and what was the impact on humans. Of course, we know that Marie Curie unfortunately died of radiation sickness, and that also kind of encouraged a lot of studies into it. And then 1940s and 60s was basically the Great Wars, and then it culminated in the atomic bomb and radiation. So this is the time that this pioneer, Leon Ordis Jacobson, he discovered and published his study on the role of spleen in radiation injury and recovery, which basically he did a beautiful experiment. He exposed mice to radiation, found that they died, obviously, but he also found that if he could shield their spleen and their thigh bones, whichever marrow is made, then they survive. So that's kind of like set the ball rolling, saying, okay, I know that there's some kind of a stem cells in those two areas, which if I can harbor, I can have a transplant. And this went on with these two American pioneers, E. Donald Thomas, who went on to actually win the Nobel Prize, and they were the pioneers of BMT. In France, there was Georges Mathé, where he actually shook the medical world when he kind of announced in 1963 that he had cured a patient of leukemia by means of a bone marrow transplant. And it showed that this stem cells does not only heal from radiation damage, it can also fight cancer, which was quite an amazing thing, and it stands true even now. And since the 1970s and 80s, we've had a rapid progression in the use of transplant. We've had multiple transplant centers set up across the world. And then by the end of the decade, we had the international transplant registries, and the European bone marrow registry had been set up, through which we can access and get to find donors for our patient. And these large data sets made it possible, various studies to say that what are the factors which relates to better or worse outcomes. We had new drugs, we had new antibiotics, we had new cells of making transplants more and more safe, and all of which basically culminated in the state where we are today, where more and more transplants are being done, more and more units are being opened up. So when we talk about stem cell transplant, there are two basic types. One is autologous and the second is allogenic. So what are these two? So very simply, an autologous transplant would mean that we would collect the stem cell from the patient himself. And this can be collected either from his bone marrow or from his blood. We would process this product of stem cells from the patient to purify, we would concentrate it, we would quantify it to find out how many stem cells are there. And there is a test there called the CD34 count, by which we find out what's the stem cell, how much there is. We look at its microbiological criteria, that it's sterile, and after it meets all the criteria, it is cryopreserved, it's frozen down. Once we have frozen, we then expose the patient to chemotherapy, high-dose chemotherapy or high-dose radiation. Now, this radiation or chemo is enough to kill off any cancer cells, and then these cells are given back to the patient or reinfused back. So the patient's own stem cells are used to treat him, and this is what an autologous transplant is. The other type of transplant is an allogenic transplant, where we need a donor from outside. So here, the voluntary donor, it can be a voluntary unrelated donor. It might be a related family donor who may be full match, or nowadays what we are doing a lot is half match transplants, or what we call haploidentical, which are only 50% matched. But once we identify a donor, we do a similar procedure. We collect the stem cells either from the patient's bone or marrow. We again process it to purify and concentrate it, cryopreserve it, freeze it down, expose the patient to chemotherapy or radiation as is appropriate, and give the stem cells back to the patient. So I'll go through a couple of cases quickly to kind of give you an idea as to where we use it. So this is one of my patients who came to me a few years ago, 6-year-old boy, noted to be becoming very tired, not much energy, got a CBC done where a diagnosis of ALL was established with high blast in the peripheral film. Started on chemotherapy and achieved remission. However, within 6 months, relapsed once again. So this basically is a high-risk case, was started on second-line chemo, and though we had a remission, we know that almost 100% of these cases would relapse once again unless we do something else, something more aggressive, something more radical. And so we started looking for a donor. So when we looked at the family, we found that this kid's sister was a full complete match. So we initiated our transplant process. We got him chemotherapy, gave him total body irradiation, transplanted him, and then after a 6-week stay in the BMT unit, discharged him. So this boy is now 3 years post-transplant. The beauty is that he's off all medications, he's back to school and he's enjoying life. And that's how a transplant can actually transform lives from somebody who otherwise would not be able to see next year into somebody who's kind of like hopefully been cured for life. Madam just talked about thalassemia, so it's kind of me saying something after that is a little bit too much, but I'll talk about a typical case. So these are the patients. So thalassemia child noted to be pale by the GP around about 6 months. And that's usually when thalassemia patients come to our attention. Follow-up showed frequent infections, severe pallor, severe anemia. And then we diagnosed the child as thalassemia and started on regular blood transfusion. Mother became pregnant with the second child after 2 years. And Madam just alluded to that whenever there is a second child in the family, extremely important to get antenatal testing done at about 10 to 12 weeks to confirm that the patient does not have thalassemia. In this case, parents banked the stem cells, and after delivery, we found that the next sibling was again a perfect 10 out of 10 match. We took the stem cells from the brother at the age of 1.5 years. At that time, this was a really tiny tot. We had problems because the patient was A positive and the donor had a blood group of B. So we've been hearing about blood throughout the day. And you know that normally when we transfuse, we need to have blood group matched. But we don't have that luxury in the transplant world of having a donor who's perfectly genetically HLA matched and has a blood group match as well. So quite often we are faced with this issue of that our donor is completely diametrically opposite blood group from the recipient. And we have basically protocols by which we can transplant these patients as well. It's a little bit too complicated for me to go into that right now, but the story ended well. We managed to get the transplant done. The patient, this was one of our first patients that we transplanted almost about 10 years ago. And this boy is now very well, very healthy and starting college. So this was him at the time, this girl, this was the girl at the point of her initial admission. This was the life-saving younger brother, and then we send them home at that point. So again, same point that when you have thalassemia, which Madam alluded to, that if we can do a transplant, if you have a good donor, we should do it as soon as possible. My third case is a child with aplastic anemia who basically presented with a low HB, low white cells and low platelets, with petechiae, bruises, and we confirmed the diagnosis that this patient had aplastic anemia on a bone marrow test. He was quite unwell. He needed platelets almost each and every week and needed blood transfusions every 2 weeks. He was in and out of the hospital regularly and repeatedly with recurrent infections. So with this patient, we started to look for a match and we looked at the unrelated donor registries. So thankfully now we have quite a few registries based out of India where we can search for a donor. Dattri Blood Bank is one in South India where probably they have the largest number of donors. And then there's DKMS, which is a German registry, which also has a number of donors we can search. This boy was lucky that there was a full 10 out of 10 match donor identified in the registry. And really important, the donor consented to donate. And this is quite an interesting concept in India, which is quite different from UK and US, where if you have a donor that's a match, usually the donor becomes really excited and happy to donate. Out here, we have the reverse, where many of our donors, once they know that they have a match and they can potentially save a life, somehow they refuse to donate, and that's a topic for another day. The donor health screening was passed. We airlifted the stem cells, we checked and triaged them down, admitted the patient, transplanted, and discharged him after 6 weeks. And this boy now is 6 years post his transplant and he's doing well. My fourth case is a case with a sickle cell disease, and this is another disease that's actually been something that really interests me. So this boy is from Orissa. diagnosed with sickle cell disease at the age of 3 years and needed transfusions every 3 to 4 months. So blood transfusion might only be about 3 times or 4 times a year. But if we looked at his quality of life over the last 4 years, he had severe painful crisis. He has admitted multiple times with major infections, pneumonia, bony infarction, and a suspected stroke. And many of the severe sicklers that are out there may have an extremely aggressive, extremely poor, extremely bad phenotype, where they have repeated infections like this, and their quality of life can be very, very poor. So with this patient, we again started to look for a cure. Now, unfortunately, we looked at matches in the family. There were no full matches. So we started looking for an unrelated donor match in the various registries. We could not find any donors in the registry. So we decided to go for this haploidentical transplant. Now, I mentioned that the sister was not a full match, but she was 50% matched. So we went ahead with this new type of transplant, and I'll come back to that, called haploidentical, which basically means you're half matched to the patient. And this again was a complicated transplant because she had very high level of antibodies against the brother, which means that when we give the cells, they would have a normal tendency to kill off the brother's cells. And if you have them, the brother had high level of antibodies against the sister. So which means that when we give the stem cells, the brother's own cells would tend to kill off the donated cells. And we had to kind of give further immunotherapy to counter that. But long story short, boy is doing well, 4 years post-transplant, starting his own business, and it went into the press. But so question is, I hope that has given you some idea of where we should be doing a transplant. So what are the diseases where we would consider doing a transplant? And I'll divide it into two, and I'll take a few minutes over that. We can divide it into doing a transplant for malignant diseases and non-malignant diseases. So when we talk about, malignant diseases, there are the usual ones are where if you have a relapsed disease, whether it be a relapsed AML, acute myeloid leukemia, an acute lymphoid leukemia, a lymphoma, or a multiple myeloma, or a neuroblastoma, all of these can be treated and cured with a PMP. We also have the other cancers in which also a transplant can be very useful, including bone tumors, some brain tumors, some kidney, renal tumors, where also it can be done. And then, of course, we have the non-malignant diseases. These are the hematological disorders where we do a transplant. And we heard a few of them: aplastic anemia, thalassemia, sickle cell disease, Fanconi's diamond blackfen. But also quite important are the immunodeficiency disorders. Special mention I will make for SCID, the severe combined immunodeficiency. So a SCID child, basically the only treatment that can cure and that can save a life is a transplant. And this is one of those transplant emergencies that if we diagnose somebody with SCID, we should plan to do a transplant as soon as possible. We have all the other immunodeficiencies as well, where again, without a transplant, the patient will not really survive. We get a lot of calls from patients about whether we can do a transplant for Duchenne, spinal muscular, cerebral palsy, autism, spinal injuries. And I have to say that these are not diseases currently that we can treat with a hematopoietic stem cell transplant. There has been national guidelines that has been published by the ICMR and the government of India in 2017, and they make it very specific as to which are the diseases which I alluded to, for which we can do a transplant, and for others where it has to be considered experimental. But that's not to say that the future, it may come. And that's, I'm really hoping that we'll have more stem cell research coming in by which we can give a transplant, we can actually go forward and treat these other patients also with stem cells with the transplant and cure them. So if you look at the world and the transplant data across, and this is the transplant data from US per year, we can see that almost each and every year in the US alone, there's about 25,000 transplants that are taking place. A little more of them are autologous, about 12,000 autologous, which is basically the patient's own stem cells, and about 10,000 allogenic from somebody else. So roughly every year nowadays, about 20 to 25,000 stem cells BMTs happen in the US. And what are the indications? So if you look at that for a second, if you see the breakup before, we can see there was a lot of interest in cord blood transplants at a time, and you know that there were cord bloods being set up elsewhere. But if you look at the graph for cord blood, we can see that the enthusiasm for cord cell transplants have dropped off. And this is because if you follow this kind of orangey line out here, this is because the unrelated donor transplants took off in a big way. This has started from the 2000. And then if you look at the green line, this is the half-matched transplant line. And this is what we have seen in the last decade from 2010, 2015 onwards. More and more transplants are being done which are half-matched rather than cords. And in fact, even unrelated donor transplants have taken a dip, because this is what's coming up all the time, that we can now actually do a transplant for many of our patients by just using a half-matched donor. What diseases are being treated by a transplant in the US? Multiple myeloma in the adult world is the commonest, followed by AML, NHL, ALL, MDS, etc. What about India? So we now have a very robust Indian stem cell and marrow registry. And all the stem cell centers in India, all the HSCT centers are voluntarily, we would actually report our numbers to this registry to see what we are doing. And there are a total of 110 centers in India which are doing transplants. So if you look at the number of transplants that are taking place in India, it's like a fraction of what happens in US, in spite of having a population that's about 4 times more. That we are only doing about 2,500 transplants every year. But still, that's more, and it's kind of gradually going up, except for obviously because of the pandemic. We did not have as many transplants in 2020, but 21, 22, it's again starting to come up. And if you look at again the trend between full allogenic transplants from a donor and autologous, we can see a similar, that slowly the numbers are starting to creep up. Indications are again kind of similar, with one major exception, which I'll come to. In the adult world, multiple myeloma is the commonest indication for a transplant. But in India, a large number of transplants are done for thalassemia, because we have the largest thalassomic population almost in the world. We have about 10,000 children that are still born in India each and every year with thalassemia major, and that's something we need to stop. We also have a large number of transplants for sickles, for bone marrow failure, severe aplastic anemia. If we look at the number of centers that are registered, and this is really quite encouraging, because we can see over the last few years, more and more centers are being established across India, so that we can have more patients being able to access this kind of a care. So there are some myths about BMT. The first one, and the biggest one, which all patients come to thinking, you talk about transplant, you talk about surgery. So it's kind of, in fact, on the day of the transplant, when they see us coming in and infusing the stem cells, it's just like a blood transfusion. It's almost a letdown for them. They have been building themselves up. So it's a medical procedure, but it's probably one of the most complex medical procedures ever. We have to have the patients isolated in germ-free, positive pressure, HEPA-filtered room for up to 6 weeks with absolutely no contact with the family, just to protect them from infections. There's also this myth that it can cure almost any disease. I'm hoping someday it would, but not quite today. And then there are some people who still believe it's experimental. It's not. It's this rigorous evidence-based standardized therapy for a lot of diseases, which I alluded to. There are some quite interesting facts. The first thing is that when we do a transplant across blood groups, the patient's blood group gets changed. And Dr. Ruhi Mehra, who spoke before me, knows about that. And we talked to her that we have to change the blood transfusion for the patient after the transplant from the one that was before to the one to the donor. And in fact, if the patient's DNA profile gets changed, and that has got forensic implication. And in fact, there has been at least one case I know of where the police services actually arrested the wrong person who was the stem cell donor, whereas the criminal was somebody to whom he transplanted. The other really interesting thing about BMT is that it is possible in a stem cell transplant to stop all immunosuppression in almost every patient after a year, which means unlike a liver transplant or a renal transplant, where most of these patients would remain on immunosuppression lifelong, our patients can get on with their life and live a completely normal life. So how do we do a transplant? So we need to find a good donor. We get the patient healthy. We admit, get rid of the defective marrow, whether it's a diseased marrow because of a malignancy or it's a defective marrow because of a marrow failure syndrome. We inject healthy bone marrow from the donor to the patient, wait for it to start to grow and then discharge. So I'll go through this in a little bit of time. So the first step is we need to choose the right patient and kind of ask ourselves the question that can this disease be treated and cured by a BMT? And thankfully, we have guidelines to kind of choose the patients which can. And then we need to see whether the patient is fit for a BMT by age, by physical condition and comorbidities. But age nowadays is no longer a bar, because even infants as well as 80-year-olds can now safely have a transplant, and we have done that as well. We need to find the right donor, which possibly is one of the most important steps. And we first of all look in the family, and we run this test called HLA typing to find a sibling or a family member who's genetically identical by HLA type, which we do to find if that person can be a donor. And you can see in this little cartoon, if this kind of represents the 5 children, child 1 is almost identical to child, it is identical to child 2 because they inherited the same set of genes from both parents. So this child can be the ideal donor for child 1. We also look at stem cell registries, and I alluded to these 2 big registries that are in India, and they respond back really quickly that when we send them our donor request, usually we get a reply back within 2 to 3 days to say whether they have a donor for our patient or not. And sometimes, rarely, even a parent might be a fully matched donor for a patient, and this can happen in less than 1% of times. We had one child whose mother was a fully matched donor, and we ran that transplant, and the child's doing well. But nowadays, what we have is that the question is that when you don't have a sibling, a brother or sister who's a donor, or an outside, can we use the father or the mother? And this is what has been the sea change, the paradigm change that has happened in the transplant world, where we can use the stem cells from almost anybody. So, cause a major issue for a transplant has always been finding a fully matched donor, and less than 10% cases would we find a donor in the family. A reason for that is now we have smaller family sizes, so it's less number of people I can screen to be a donor. And even though I've said that donor registries are there, the numbers are still small. So Madam talked about how the number of donors in the registry are about 5 lakhs. Now, if you compare that to any of the international registry, where the number of donors in them are actually in millions, it means that we stand a less than 5% chance of finding a match. So in these cases, there is this new type of transplant called haploidentical transplant. And this was a beautiful paper that was published just about 8 to 10 years ago, where they used something very clever. They used this drug called cyclophosphamide after the stem cells were infused. And what it does, it kind of kills off any alloreactive T cells that start to multiply when you put in the cells from somebody different. It's basically, by this way, we now can actually transplant each and everybody, which means that all of us have 50% of our genes matched to our parents. So which means every child can be a donor for a parent, and every parent can be a donor for a patient. It is a bit complicated, but really it can be done. But after the patient is admitted, we have to destroy the abnormal marrow. And we do that either with high dose radiation or with chemotherapy, or usually a combination of both. Collect the stem cells, which can either be the marrow itself, which we do in the theater and on the OT, and collect it from the posterior iliac crest, as me and my colleague doing that for a patient. Or nowadays, we can also collect it from the peripheral blood. And this is basically an apheresis unit by which the donor's stem cells are being collected in the apheresis machine. And after that, as I said, the stem cell infusion, and it's basically is kind of giving the stem cells almost like a blood transfusion back to the patient. And after that, we need to dampen down the patient's own immune system for up to about, few weeks to a few months, because unless we dampen down the patient's own immune system, they will not accept the donated stem cells. We have to be aware that our patients get severely cytopenic for up to 2 to 3 weeks. So when I say severely cytopenic, we're talking about white cell counts less than 10 or sitting at 0. So it's not 2,000, 4,000, 6,000. It really is 0, which means that infections are extremely common. We need strict isolation. We have a lot of backup there to try and protect them. There are a lot of complications we watch out for, but hopefully we get them better and then we send them home. Our patients need follow-up for up to a year. Usually after about a year, we're able to discharge most patients from our care. And this follow-up period for up to a year is possibly the most complex and more complex than transplant itself, because we watch for graft versus host disease, we watch for infections, graft failure, and titrating immunosuppression, I always feel is more of an art than science. You look at the patient, see how things are, and decide what's exactly the right dose of immunosuppression you need to do. Some of them need an additional stem cell therapy to boost up their cells. So why are transplants so difficult? I mean, you need the infrastructure, you need HEPA-filtered positive pressure rooms, air handling units, stem cell labs, dedicated blood bank service. But it's actually the multi-speciality backup and the technical know-how, which is quite a difficult thing to actually get together. So, I mean, Madam Manglani has done that twice, so she knows how it is. So I'll kind of end with a bit of some of the work that we've done. So one of the things we looked at for sickle cell and thalassemia patients was run this HLA typing camps. And remember me talking about finding a good match. So to find a match, we do this test called an HLA typing. And usually it costs about 8 to 12,000, which can be pretty much horrific for a new family. So in partnership with a couple of our partners, we run these camps across everywhere in Maharashtra, Gujarat, Rajasthan, across India, really. And we do this HLA typing camps free of charge for thalassemia patients. And if they have, if we find that we identify a donor, we can then actually tell them about going up for a transplant. So this is our own small data. This is only looking at thalassemia patients, not everybody else. And our survival figures and thalassemia survival figures are kind of at par with the rest. These are the transplants we have done over the last few years. The green bars are the total, and you can see I'm kind of quite proud that we've always done more transplants than my other colleagues there. Majority of our work has again been with thalassemia major in pediatrics, but we've also treated relapsed ALLs, AMLs, neuroblastomas, and other patients. We've very recently had a good initiative started, which with Coal India, by which we can actually now offer a transplant for our patients with their help at no cost to them at all, and we signed the MOU. I'll finish there with grateful thanks to my entire team and all of our supporters who have kind of helped us on this journey and brought us where we are. I hope I've been able to give you some idea what a transplant is, and it's a complicated matter, but I'm hoping you have some insight of the work that we do. Thank you so much.
Excellent talk.
I'm just going to stop screen share.
Yeah. So many concepts.
Dr. Shantanu, there was one very interesting thing which you put up, that the blood group changes after the bone marrow transplant. And हम यहाँ पे छाती ठोक के सब पेशेंट को बोलते हैं कि ब्लड ग्रुप तुम्हारे हाथ पे टैटू करके रखो, यही एक चीज होती है जिंदगी में कभी नहीं बदलती. And today you have changed that concept also.
Yeah, that's true.
So, thank you so much, Shantanu sir, for elaborating us with such a new facts which we were really unaware about it. Thank you so much.
Thank you. Thank you so much.
Let's move ahead. The next speaker is Dr. Nandini Madam. She has experience of more than 20 years. She's working as a Deputy Director at Regenerative Medicine at Neurogen Brain and Spine Institute, Navi Mumbai. She has more than 104 articles in the national and international journals, and she is also editor-in-chief of Indian Journal of Stem Cell Therapy and chairperson at Institution of Committee for Stem Cell Research. Welcome, madam. Over to you. Dr. Nandini, madam.
Yeah. Sorry. Yeah. Good afternoon, everyone. I hope I'm visible. Thank you so much for inviting me for this session on all about blood. I think my invitation, I'm on basically here on behalf of Dr. Alok Sharma. Unfortunately, he could not be there. But since Dr. Sharma is a neurosurgeon and we are in the blood bone marrow area space, but in a non-homologous use. So today's talk is going to be a little bit different from what has been so far seen. Can you see my screen? Is my screen visible?
Yes, yes.
Yes. Okay, thank you. I'm just trying to see where I can make it full screen. So the topic given is stem cell therapy and banking. So it's an eclectic topic having two portions. So a lot of discussion has, or some of the discussion has already happened on the cord blood use. I'm going to just briefly, since it's part of the part of my topic, I will brief a little bit about what stem cell therapy is and the components and the cord blood a little bit. Sorry, I'm just trying to see where the full screen, I'm not able to get. Sorry. Okay.
Ma'am, right hand.
But actually, the panel is getting. The panel is. Yeah. Yes. Yeah. So stem cell therapy and banking. So stem cell therapy is a field of regenerative medicine. A lot of talk has been done on bone marrow transplantation, which also, of course, is a part of stem cell therapy, where use of stem cells to repair damaged or destroyed cells. I hope I'm visible and the screen is being seen. Yeah. So stem cells are.
Yes, madam, yes.
Thank you. Stem cells are precursors that have capacity to self-renew and generate multiple mature cells. And we know that they have different mechanism of action. They have paracrine effect, they transdifferentiate, they can fuse into other cells, even mitochondrial transfer functioning, as well as now a new method, that is the release of exosomes has been seen, which helps to release microvesicles and stimulate repair and regeneration. So the stem cells have differing action, and one of the main thing is that these cells can multiply, replicate, and differentiate into many different cell types. They have paracrine mechanism, they stimulate cell proliferation, induce angiogenesis, release antioxidants, and help in preventing apoptosis. Exosomes, again, the mechanism of exosome is release of microRNAs, which are responsible for a therapeutic effect. So there are, apart from growth factor release, exosome release is a new mechanism now, which is being found out, and which reduces the inflammation. Here, this is more relevant to what we do, the brain. Helps stimulate the angiogenesis, neurite remodeling, and improve neurological function, improved angiogenesis. One of the ways that hematopoietic stem cells and mesenchymal stem cells work on. And based on the different ways that it can be classified is based on potency, based on transplantation, how you are giving the transplantation and how much you have manipulated the cells and where are you sourced it from. So these, I think this is common information, totipotent, where all germ layers can be formed. Embryonic stem cells are the source of such totipotent cells. Pluripotent, where only the 3 germ layers can be formed, but no placenta. Multipotent, where closely related family of cells can be formed, and unipotent, only one type of cell. So this has been mentioned by Dr. Sen also. Autologous, when we take from our own body and transplant it back into our own body. Allogenic, when taken from a donor. Minimal manipulation, when you just purify the cells, centrifuge it, separate it, harvest, and inject back. And more than minimal manipulation is when you separate it, you change either the genetic material or you multiply it so that there is a possibility of mutations or change in the type of cells that were initially harvested. So that is more than minimal manipulation. Now, depending on where you source these stem cells from, they can be embryonic, from the embryo, from 3 to 4 days embryo, which we are aware of. Cord blood, lot of talk has been on cord blood stem cells. Adult stem cells, again from the bone marrow, from adipose tissue. Now even the dental sources, dental stem cells have been now discovered. So many of the organs in our body have stem cells, and from our own body also stem cells can help regenerate our own maladies. Induced pluripotent stem cells, recent Nobel Prize in 2012 awarded for this discovery of being able to convert an adult cell into an embryonic type cell. So by stimulating a skin cell, you can actually convert it and make it, remind it how was it when it was a small child. So induced pluripotent stem cell has a lot of potential, lot of possibility. Embryonic stem cells, advantages, pluripotency, but of course disadvantages, tumorogenicity, as well as ethical concerns that you are killing an embryo. Umbilical cord blood cells, hence also a part of adult stem cells. It's easy to collect, no risk, usually when done properly to mother or child. Less time needed for processing, less stringent antigen typing, especially when you are doing for hematopoietic disorders. But of course, engraftment can be slower, amount of cells that you get is limited. Storage has to be done very properly with good quality control. Long-term storage still being understood. How long can you store with viability intact? Long-term cost and quality control is important. Adult stem cells, replenishable, can be taken from our own body, comes back. That's why bone marrow transplantation is so much being recommended. It is safe. There are no ethical issues. You're not killing an embryo. It is effective for a whole lot of disorders, less likely to be rejected, especially in autologous use. But of course, has restricted lineage potential. Induced pluripotent stem cells, abundant cells from donors can be used. No issues of histocompatibility. We're still awaiting its use. Lot of work being happening for retina, as well as for even for sickle cell and platelet disorders. Disadvantages that we have to ensure reproducibility and find a way to maintain its differentiated state so that it doesn't go back to the embryonic state. Genomic instability is an issue, and also the possibility of development of cancer is still not completely ruled out. So a little bit about cord blood banking, because that was in the topic that we know that cord blood is a very good source. But apart from the cord blood from the vein, another source is the Wharton's jelly, the mesenchymal stem cells. So either or both can be preserved at the time of birth. And why should we save, especially if there is a family history of blood disorders or serious genetic disorders, then cord blood of a sibling can be stored. A lot of work is happening to look at what best indications can cord blood be used for. It can work as a good biological match. Cord blood can be either stored in a public bank or in a private bank. Now there are different types of bankings, and collection is quite simple.
Madam, are the slides going up?
That's what I was asking. Can you not see?
What is one slide only I could see.
Oh.
Do you need to go on April?
Madam, slideshow is not running. Slideshow is not running.
It's not. That's what I was. Just a second, sir. That's what I was asking. Whether
Madam, just see, and madam, you just verify. And I think.
Let me share again. Let me share.
No, madam, you have to go in the slideshow. Just slideshow.
Yeah.
Slowly forward the slideshow.
Right side, upper slideshow.
Actually, what happened? I think I've gone back to my own desktop.
Yeah.
That's where it's. That's why I was asking whether you are able to see. Let me screen share again. Just a second. Oh God. This happens to me many times.
On the top, you go to stop share first, Dr. Nandini.
Yes, I'm stopped. Yeah, stop it now. And now screen share.
Yeah.
Yeah,
and
but
then slideshow, madam.
Yeah.
Now go into slideshow. Even on the top, there is a menu with slideshow. You could
Is
use
it
that.
now is it moving?
No, madam.
No,
Slideshow.
it's not gone into slideshow.
Top bar, horizontal bar. Home के बाजू में insert design animation slideshow.
Yes.
Left side corner.
Stop
Home.
share. Now I'm.
No, your screen is now got.
Now can you see the screen? No.
Yeah,
Yeah,
we
now
can
it
see
is
now.
in slideshow.
Yeah.
Now
Yeah.
it is
Now it is in slideshow.
Yeah, now it is in slideshow.
Okay. And is it moving now? Oh, it's not moving now.
I think you need to close your PowerPoint and open again.
Okay.
Because I think 2 screens might have opened on your desktop.
Yes, possible. Yes. I will just stop and close again. Just give me. It's not a screen.
When you're on Zoom, it takes longer to close to open.
Yeah. Exactly. So I've opened mine now.
And after opening, you go to Zoom and come on Zoom and then share.
Share, yes. Yes.
Yeah.
Okay.
Let that be in the background, then it will be easy.
Screen share. Is it seen now? My
Yeah. It's come on.
Now I have to
Slideshow.
I'm trying, but it's not going. Now is it seen now?
Yeah, screen is seen, ma'am.
Moving? Is it moving
Screen
now?
is seen, but
No.
no. It's not gone into slideshow on the screen.
Ma'am, just a second. When you are sharing your screen, what is the this which you are selecting? It gives you options at that time. When you are opting for slide share, you are sharing one window, one screen. What are you choosing in that?
Select a window. So it's showing Microsoft.
Show your select the window which shows your presentation, and then you.
That's what I did. Now is it?
Screen is seen actually, but slideshow is not running.
It's not happening. I don't know which one is being seen.
Try slideshow icon, madam, which is on the left side.
You go on
Ma'am,
the
can
top.
you share the entire screen? That would
No,
Yeah,
you
that's what.
cannot
If
do
he
that.
goes to slideshow, entire screen will be visible. That vertical slide bar will go.
You go on the top of the screen and then you can see the slideshow.
The view, speaker gallery, full screen I should go. Yeah, it's full screen. Screen share.
No. There's a slideshow icon on top also on the panel.
Yeah, on the horizontal bar.
Yeah. There also you can click and go into slideshow.
It is up on the screen. Up.
See that
After animations, there's home, insert,
Animation.
design, animations, and slideshow.
Yeah, okay.
Yeah,
Yes, that
click
one.
that.
Yes. Start slideshow. Start from beginning or whatever.
What is it now?
Yeah. From
beginning ही करना
from-
पड़ेगा, madam.
Yeah,
तो
from
पहले का
beginning.
slide.
Click it again, click it.
Again click it, ma'am.
Yeah, now
Start
you see from beginning.
beginning ही करना
Below
पड़ेगा.
that you are seeing from beginning at the corner, left hand corner.
Left
Up
hand.
only, on
Home
top
के नीचे.
only.
अभी हो रहा है? नहीं.
Left नहीं,
Home
madam.
के
Left
नीचे.
corner. Home के नीचे. Home
Home
के
के
बगल.
नीचे है ना from beginning. You have to click that.
Uppermost home है ना left का, उसके नीचे. हाँ, yes, उसके नीचे, madam. हाँ, yeah, that. That you have to click.
अभी?
From beginning. अभी
Is it moving?
नहीं हो रहा है.
अभी भी नहीं हो रहा है?
Click हुआ लेकिन वो नहीं आया. मतलब it should become full screen and go inside slideshow. It is not going.
It's not
gone into
Click properly. Click properly.
Yeah, okay. From beginning.
यहाँ पे मैडम.
हाँ, from beginning किया, फिर अभी move नहीं हो रहा है, अभी मैं move कर रही हूँ तो.
From current slide
Ma'am,
करके
click
देखो,
on
madam.
every slide
Current
that you're
slide.
going to talk on. It will go on to the next slide.
From current slide.
But it's moving on my screen, but is it not moving for you?
It's
Ma'am,
what
now
are
it
the
has
stem
come on
cells slide is
what
showing
are
here?
stem
What are the stem
cells?
cells?
So
Now paracrine mechanism.
And it's not yet on slideshow. It's not in slideshow.
Not yet.
But even if it is not on slideshow, ma'am, you can click on every slide.
know.
The
Yes,
slide
madam.
will
Yeah.
open
Click
up.
on every slide.
Yeah.
Yes.
When you're talking,
Yeah, I think
click on the slide that you're talking about.
yeah.
Which number of slide you are speaking, that slide can be clicked now.
Share screen again. Okay. Is it moving now? And when I'm clicking on it?
Yeah.
Now it's going.
Yeah.
Yeah.
The slideshow is not working.
Slideshow is not working.
But you click on every slide, ma'am.
Can I see now? Is it? No. Is it moving now? No. The whole screen is not.
Third slide is seen now. Third. Stay. What is staying?
Ma'am, click on the slides, please.
Yes, yes.
Direct.
Yes, I will do that. So you can see what are stem cells, right? And after that,
Yeah. Click on the slide only, madam. Slide should not.
So here mechanism, multiplication and differentiation. Can you see this? Are you able to see this slide of multiplication and differentiation? Yes. Okay. Okay. So I had gone past this. So paracrine mechanism, exosomes, improved blood supply. Now the stem cells. Is it? Okay. So the classification, I talked about the classification of the stem cells based on the potency, then based on the way that transplantation can occur, and the level of manipulation. So minimal manipulation versus more than minimal manipulation, and based on the source. So embryonic, umbilical cord, adult stem cells, and induced pluripotent stem cells. I had gone next to a little bit about embryonic. Embryonic pluripotent, thus any type of cell can be created outside the body, but disadvantages possible of tumorigenicity or teratomas and ethical concerns that you're killing an embryo. Cord blood has advantage of ease of collection, no risk to mother or child, no killing an embryo, less time for processing, and less stringent typing while transplantation in blood disorders. But disadvantages, slow engraftment, limited cell dosage. For adult population, it would be difficult. Storage issues, unknown length of viability when long-term storage, and cost of storage as well as quality control needs to be exemplary. Adult stem cells are safe, effective in a wide variety of disorders, less likely to be rejected and easily available. But of course, they have restricted lineage potential. Induced pluripotent cells, a new type of stem cells from the skin, for example, from the skin of an individual, the skin can be converted into embryonic type stem cells. And however, it's a new invention. In 2012, a Nobel Prize was awarded for this condition, for this particular discovery. A lot of work is happening for retinal stem cell, for retinal, for retinitis pigmentosa, or for degenerative retinal conditions, as well as for sickle cell and platelets disorders. Routes can be, depending on where do you want to inject them, it can be in the spinal fluid for brain conditions, or intracerebral or intranasal. We can inject intramuscular, intraarticular for joint conditions. Cord blood banking, as I said, we can take cord blood from the blood, as well as the Wharton's jelly is a very good source of mesenchymal stem cells. So depending on, either you can save the cord blood or the Wharton's jelly, or both. It is a very good source. Cord blood is a very good, it's usually a very good match for siblings. And many people store it if there is a sibling in the family with sickle cell anemia or thalassemia blood disorders. It can be of a great help as a biological match. And cord blood donation, it can be a cord blood public bank can be used, there, or a private bank. So collection is very simple, but it has to be done at the right time. So there are a lot of queries when it should be done and how much it should be collected. It is the anticoagulant used generally is a citrate dextrose or a citrate phosphate dextrose, and it has to be collected within 15 minutes of the birth. But in high-risk pregnancies, it cannot be collected. Actually, once it is collected, it is taken to the bank and preserved in liquid nitrogen, tested for HLA typing or for virus, and then stored in cord blood banks. Complications and ethical concerns. There could be a loss of blood volume while collecting. It's important to collect it at a particular time so that the child does not suffer because of the blood collection. It has to be done by a properly trained and qualified personnel. The number of cell count is very important for future use. And though cord blood collection should not change, and it should be done in such a way that the routine cord blood clamping should not be affected. So as I said, Kermi Public Bank, where storage is free of cost, it is done as on a voluntary basis, and public banks can be a very good source in the long term for many conditions. Private bank has limited use because it depends on just, it helps for your family, and there is now community private banking where the community of private bankers can be benefited. So private bank has limited role, public bank would have a bigger role in the long term. Now, non-homologous use of cord blood or placental derived stem cells, you all know about the homologous uses, but non-homologous use, one of the very recent study is used in COVID. This was a study done as a collaboration between Sion, Relabs, and Neurogen. This was a phase 1 clinical trial for intravenous administration of mesenchymal stem cells derived from umbilical cord and placenta in patients with moderate COVID-19 virus pneumonia, results of the stage 1. So it was a safety trial, which was done with 20 patients in Sion Hospital. And there were 2 stages. Stage 1 with 10 patients where 100 million placental cells were injected, mesenchymal stem cell, and stage 2 where 200 million were injected. So they were followed for 6 months, and there were no adverse events, there was no deterioration. Most of the patients improved with reduction in their markers, as well as improvement in their CT scan. So all the symptoms improved within 10 to 11 days. So this was the first of its kind trial which was done in India. So this is just to give an example of non-homologous use of cord blood. Now the second part of my talk was to be based on stem cell therapy or clinical application of stem cells. It has a lot of potential in regenerative medicine for cardiac, for muscle, for brain, for liver, and of course a lot of potential still being understood even for arthritis. Our focus is on neurological condition, and one of the in fact, the preceding talk by Dr. Sain, he did make a point that whether neurological conditions can be benefited by using bone marrow derived cells, he was in fact quite encouraging about the possibility, but was not sure of the evidence. So that's where I would like to bring forth a little bit, maybe in 5 minutes, evidence on non-homologous use and especially neurological conditions. So bone marrow, we choose to work with bone marrow derived stem cells because it is safe, easily obtainable, non-tumorigenic, no rejection issue, and we are not killing an embryo. Now, bone marrow mononuclear cells, these are heterologous population, has hematopoietic stem cell, mesenchymal stem cells, and endothelial progenitor cell precursors, very small embryonic-like stem cells. And the cumulative effect of these subtractions are advantageous, we feel, especially in neurological conditions. And there have been studies before also where these isolated bone marrow mononuclear cell fractions have been used, and it has been found that these have neuronal protective roles and hence works well together. These cells for best efficacy we find has to be injected intrathecally. Intrathecal injection is minimally invasive, safe, no major side effects. Cells home on to the injured area, and no dilution in the liver when we, for example, when we give systemically IV. Now, why intrathecal? There are studies which show that when hematopoietic stem cells or CD34 cells are connected or are attached to magnetic beads and injected in a spinal cord injury model, these cells do reach the site of injury maximally. So now evidence, whatever I'm going to present here is based on published data, and the question was whether in autism, does it work? The first ever publication in the world, in fact, came from, published in the Stem Cell International Journal in 2013, came from Neurogen, where we published a data of 32 patients undergoing intrathecal bone marrow-derived mononuclear cell injection, so non-homologous use here. And we published that in all the scales clinically, there was significant improvement in all different domains in autism: social relationship, emotional responsiveness, speech and language behavior pattern, sensory aspects, and cognitive component, and improvement in all the clinical areas. After that, worldwide, there has been evidence both for cord blood as well as for bone marrow derived cells in various parts of the world, including Duke University, where cord blood has been used. The second publication from Neurogen came in 2020 recently, published in the American Journal of Stem Cells, where data of 254 patients was published with similar procedure, with outcome measure, clinical as well as brain scans. So clinically, we found that improvement in social interaction, eye contact improved, attention concentration became better, stereotypical behavior reduced, aggressiveness reduced, hyperactivity reduced, self-injurious behavior reduced, sitting tolerance, command following. So all areas clinically showed improvement, both in clinical scales as well as used is ISA and CARS. Age-wise, when you look at the severity both in mild, moderate, there was good improvement, 93% improvement. When you look at the age, when the child comes, less than 5 years showed the best. We know that brain plasticity is best when treated earlier. So early intervention seems to be the rule of the thumb which we should use now. Less than 5 years, 97 to 98% is the success rate. Between 5 to 10 years, 94 to 95%, and then 10 to 15 years, 90% success rate. Gender-wise, both girls as well as male and females improved equally, and the earlier they came to us, better the results. Now we looked at objective brain scans here. You can see a PET CT scan of the brain. You can see these blue areas indicate low functioning brain. This is before the treatment, and after you can see that the blue becoming green, indicative of improved metabolic activity. So this is evidence on imaging. So we have clinical evidence and you have imaging evidence. Here you can see before the treatment blue areas and then green areas. So these are objective evidences before and after in the brain scan as far as autism is concerned. These are the publications, almost 16 publications from Neurogen itself. The other use that or evidence that other areas that we have worked on is cerebral palsy. You can see severe brain damage here, the black area being scarring of the brain. The blue area indicates low functioning areas. We know that generally rehabilitation as well as medications for epilepsy as well as the Botox for muscles and orthopedic or surgical correction of the spasticity are the only treatment options. But however, the brain functioning doesn't seem to be improved by all these other methods, and hence we published this study in 2015 showing that autologous bone marrow derived mononuclear cells were a possible therapeutic option for cerebral palsy. This was a study of 40 patients from differing age group as well as 26 male and 14 females. And we generally found improvement in oromotor function, speech improved, standing balance, walking, ambulation, leg movement. So progressive improvement with in function as well as quality of life with stem cell and rehabilitation, or mononuclear cell injection and rehabilitation. When we look at the brain imaging, we can see here before the treatment, the blue areas before the treatment. This you can see frontoparietal damage before the treatment, and 6 months later, you can see an improvement in the brain functioning as far as imaging is concerned. So this, along with rehabilitation, seems to be the key here. Similarly, in intellectual disability, this we did a comparison study because, of course, you want to know whether stem cell is alone responsible or rehabilitation. So here what we did was we did a comparison of 58 patients and 29 having only intervention with rehabilitation and 29 with only rehabilitation. So this comparison, when you see that, yes, the blue indicates intervention group and orange indicates the rehabilitation group. In rehabilitation group, you do see improvement in almost 80% of the patients, or 20 did not show any improvement at all. Most of the patients showed mild improvement, while few of them showed moderate to significant. As opposed to an intervention group, almost 100% showed improvement, but a big 60% showed significant improvement in their overall functioning. So that is the difference. When you combine stem cell with rehabilitation, you get a better qualitative effect. So comparison, when you look at the intervention and rehabilitation group, you see improvements in most of these areas of cognition, remote memory, problem solving, understanding of relations, social inhibition, command following, improvement in attention, concentration, aggressiveness, all these different areas, you can see improvement better in intervention group as compared to the rehabilitation. So this is again a published information. And when you look at the brain scan, you can see these areas before the treatment, the brain is extremely hypometabolic, a lot of blue areas, and 6 months later, you can see brain is much better functioning. The green and the yellow indicates good functioning brain. So most of the areas show good improvement, such as medial temporal, thalamus, cerebellum, and the cortex. So these are a few examples of non-homologous use in stem cell therapy. There is, of course, a lot of evidence coming up which needs to be looked at. There are other conditions such as spinal cord injury. I'm not sure whether I have time, which have been shown to have good improvement. Dr. Chauhan, Dr. Tiwari, can I continue?
It's okay, ma'am. Time is running up. Interesting talk.
Yeah, there is a lot more to speak. As I said, it is. Yeah, so I'm just talking about neurodevelopment, but in adults as well, we do have head injury. We can see very good improvement in head injury as well. And for example, let me show you the scan before the treatment. When there's severe head injury, severe brain damage, and after the treatment, you can see improvement in the brain functioning. Stroke also. There is a good possibility along with the combination with rehabilitation. So these are a few examples of non-homologous use of bone marrow, where we digressed a little bit here from the blood to the other areas and how bone marrow cells can be potentially useful. So I'm going to wrap up this talk with the last slide about complications. How safe is the treatment? So because we are bone marrow, we know bone marrow cells are generally safe. No tumor formation has been seen, though we have also published. Here you can see adverse events, possibility of seizures being stimulated when there is a previous history of seizure or when EEG is abnormal. And having understood that, we found that giving preemptive or perioperative epileptic cover and a long-term epileptic cover helps to reduce the possibility of this side effect further to less than 2%. So, in conclusion, adult bone marrow derived mononuclear cell therapy seems to be a safe and effective option and should be considered. Thank you. Sorry for all the confusion initially.
One small thing I wanted to mention over here is that I wanted this talk to happen because I had heard Dr. Alok Sharma on the similar topic, and I had seen the same slides also a few years down the line. And what it gave me was hope, because where autistic children are concerned, where brain damaged people are concerned, we always give up on them. You know, we do not try and we do not try to maintain it hard enough. And this is giving us hope that yes, stem cells can be a potential cure. So thank you very much, Dr. Nandini, for having stood instead of Dr. Alok and given us another ray of hope. Thank you.
Thank you so much, Madam, for such kind words and for re-emphasizing what we did want to say. I hope I've been able to do some justice within the confusion that happened today, and I apologize for all the confusion, and thank you so much for the invitation.
Thank you, ma'am.
It was an excellent talk. And I think now the final speaker is Ashwini madam.
Yes, sir. Thank you so much. Thank you so much, madam, for such a wonderful talk. And without wasting the time, we'll move ahead with the last talk, which is of Dr. Seema Jagyasi, madam. Madam is oncology and bone marrow transplant, and her core competencies are independent bone marrow transplant unit and intensive care unit management, independent intensive coronary care unit management, dialysis unit monitoring and management of all the complications, 2D echo and treadmill test procedures, independent handling of procedures like intubation, pleural tapping, and list is on and going on and on, I guess. Welcome, madam.
Thank you, AMC team, for inviting me here. And since morning, we are having this academic feast. We have seen the talks from blood transfusions, thalassemia, bone marrow transplant, stem cell therapy. Now I'll be talking a few minutes about some blood disorders, how to pick up on the routine CBC testing, what are the symptoms and how they present, and how a family physician or a physician can refer to a hematologist, what are the findings in the common CBC and other blood tests. So we will discuss about how to diagnose various blood disorders on the basis of lab investigations and other techniques. And also, I'll give you a brief idea about the prognosis and treatment options about these non-thalassemia, other hematologic disorders. Next slide. So in hematopoiesis, it's a developmental process which requires self-renewal and a well-regulated differentiation of these stem cells for maintenance of this regeneration of the blood cells. So there is a multipotent hematopoietic stem cells which differentiates into a lymphoid progenitor and a myeloid progenitor. From lymphoid progenitor, it matures into B cell, T cell, and natural killer cells. Myeloid progenitor cells, it differentiates into myeloblast, and from there we have basophils, eosinophils, neutrophils, monocytes, dendritic cells, and macrophages. And we have a red cell lineage, which is from reticulocyte, and then it is matures into the erythrocytes, and from megakaryocytes into thrombocytes, and there are something called as mast cells. So next slide. Go to previous slides. Yes. So genesis of hematologic malignancy: from lymphoid progenitor cells, the malignancies which can arise are ALL, CLL, lymphomas, and from plasma cells, the malignancy which arises is multiple myeloma. From myeloid progenitor cells, we have myeloproliferative disorders, and we have acute myeloid leukemias and chronic myeloid leukemia. Next slide. Are slides moving properly?
Yes, ma'am.
Yes, ma'am.
Okay. So now the delay in providing timely treatment. So what are the reasons in community for the treatment of hematologic disorders? So if the patient is unable to see the provider on time, if delay of patients in reaching the specialist, and delay in prompt administration of treatment. So here the primary care provider should usually is the first point of contact. So his role is very crucial in early diagnosis and timely referral and timely treatment. So hence this talk. So next slide. So we'll discuss some few common cases which are encountered by physicians. So this is a 53-year-old male. He had history of fatigue, malaise, and weight loss of 16 kg in 6 months. Next slide. His examination showed mild tachycardia and enlarged spleen up to 10 centimeter. His blood test showed hemoglobin of 10 and WBC count of 3 lakhs and platelet count of 4,29,000. Next slide. So here, what is our provisional diagnosis and what additional tests we need to advise? Next slide. So in the blood panel, the basophils in the differential count, they were 5% and there were 32% bands, 5% blasts, and segment and neutrophils were increased, the eosinophils were increased, and there was a shift to left. Next slide. Bone marrow test was done, aspiration and biopsy, and which showed normal cellularity, which showed increased basophils, eosinophils, and bands. Next slide. So here we were suspecting chronic myeloid leukemia, and we did the PH chromosome, that is 46. So here translocation 922, which can also be done on the peripheral blood, and it was positive, which is the hallmark of CML. Next slide. So here flow cytometric analysis showed CD33, CD117 positive, and there is this on the cytogenetics, BCR-ABL, that is translocation 922 present. Next slide. So after ruling out the differential diagnosis of high WBC count, which are the differential diagnosis are leukemoid reactions, which are inflammatory, where the WBC count is high, but it is usually up to 50,000. They have toxic granules present, they have Dole bodies present, and there is absence of basophilia. Other differential diagnosis here due to splenomegaly was polycythemia vera, but here there is in polycythemia vera, there is leukocytosis and thrombocytosis also, and the lab score is either normal or increased. In CML, we have the lab score is reduced. And other differential diagnosis like essential thrombocythemia, here there is marked thrombocytosis. In AML, there is absence of Philadelphia chromosome, and there are the molecular markers present for AML, which were not there in this case. Next slide. So here the diagnosis of CML was confirmed. The key features are blasts of 5% or less, and presence of CD33 and 117, and detection, most important is detection of BCR-ABL translocation. Next slide. So CML is divided into chronic phase, accelerated phase, and the blast crisis. Chronic phase carries an excellent prognosis. Here there are less than 15% of peripheral or marrow blasts. When the peripheral or marrow blasts are 15 to 30%, it is accelerated phase. And when there are more than 30%, it is the blast crisis, which is like an acute leukemia. So blast crisis carries poor prognosis. It is rapidly fatal, but of course it can be treated. And so chronic phase is now it has very good prognosis, and with the available TKIs now we can almost like cure these patients of chronic phase CML, and we can bring them into deep molecular remissions. Next slide. So here how to differentiate it between CP, AP, and blast crisis. Next slide. Treatment. Next slide, please. Treatment goals in CML. So prevent the disease progression from chronic phase to accelerated or blast crisis, and ensure the best possible duration and quality of life to bring them into deep molecular response, and to potentially we try to cure in these cases. Next slide. So according to ELN guidelines, we start them on TKIs, the first generation or second generation, and allogenic stem cell transplant, which used to be widely used in CML cases in the past, is now reserved only for relapsed refractory cases or who fail on the multiple lines of these tyrosine kinase inhibitors. So now the life of CML patients have really become easy. With these daily, they take this once a day tablet or twice a day tablet. With TKIs, they can almost achieve cure rates. Next slide. Second case is a case of 41-year-old male who had fever for since 15 days and easy fatigability. Next slide. His blood test showed on examination there was no lymph nodes, there were no liver spleen palpable, there were no signs of any bleeding disorder. His hemoglobin was 7.6. So for a male, this 7.6 hemoglobin is quite low. His platelets were 14,000 and his WBC counts were high, that is 29,000. And his differential count showed 5% promyelocyte, 81% blasts were seen. Next slide. So now what is the provisional diagnosis in this young male? And next slide. And we advise some more tests. So peripheral blood smear showed the circulating blasts, which were more than 20%. So this was a worrying feature which was pointing towards a leukemia. Now, how to differentiate which type of leukemia? We advise them flow cytometry. Next slide. So bone marrow aspiration biopsy. Next slide. Next. So bone marrow aspiration biopsy, we do morphology, staining, immunophenotyping, that is flow cytometry, and we do the cytogenetic analysis. Next slide. And molecular markers about what we are getting on the above tests. Next slide. So in aspiration and biopsy, the bone marrow was hypercellular, 28% blast in the marrow with OR rods, and 60% eosinophilic precursors were present. Next slide. So here immunophenotyping showed CD13 positive, CD33 positive. So major myeloid markers were present and these cells were MPO positive. That is myeloperoxidase positive. Next slide. So these are myeloblasts, and the diagnosis of acute myeloid leukemia, which is a dreaded malignancy, was confirmed. And here, so the common key features are more than 20% blasts in the peripheral smear or bone marrow. Presence of the blast will show CD13, CD33 positive and myeloperoxidase positive. And OR rods can be positive. Next slide. So here on the cytogenetic evaluation, in some as much as 50% cases, AML, they may not have any cytogenetic abnormalities, but then other 50% they have cytogenetic abnormalities, and these are important for prognostication. So prognosis of AML can be decided with the cytogenetic report. Next slide. Ruling out other differential diagnosis. Next slide. Next. So here CML was or a blast crisis from CML, blast crisis from this was ruled out by absence of PH chromosome, and there were no lymphoid markers. So the ALL was ruled out. The absence of JAK2 mutation ruled out other myeloproliferative disorders, and mixed phenotype acute leukemia was ruled out based on the immunophenotypic findings. Next slide. So here the diagnosis of acute myeloid leukemia, AML, was established, cytogenetics were done, and molecular tests like FLT3, NPM, and SEPA are done. They are very crucial for prognostication and deciding the treatment. So here, next slide. What is the treatment of AML? It is the induction chemotherapy and consolidation, followed by consolidation chemotherapy. Next slide. Next. So what is in the induction therapy, the chemotherapy is aimed to kill leukemia cells. Consolidation therapy after induction chemotherapy aims at preserving this remission, and post-remission therapy, it is the killing of remaining leukemia cells that may be inactive but can regrow or relapse. Next slide. Next. So based on the performance status of the patient, we offer them either the +3 induction therapy for those who are fit, and those who are not so fit, we treat them with hypomethylating agents, and then bring them in the remission, and then we consolidate them with the other treatment. And maintenance is usually not the part of AML treatment, and relapsed refractory treatment cases, they are treated with the salvage protocols like IDA, or they may be salvaged after giving chemotherapy, and then they can be taken up for stem cell transplant. Next slide. Third case is a 58-year-old male who presented with fever, breathlessness on lying flat, loss of appetite, weight loss. And his symptoms were gradually progressive. He also noted some night sweating and bone pains. Next slide. His blood parameters showed HB of 10, WBC count of 24,000, platelet count was 118,000. MCV was normal and there were no circulating blasts, 58% neutrophils. His additional tests showed elevated alkaline phosphatase and elevated LDH. Next slide. So here, next. So here we did his bone marrow examination, and his bone marrow examination showed hypercellular marrow. Fibrosis was seen in the bone marrow, grade 2, grade 3. And here they had the teardrop cells. So we suspected this as a myelofibrosis, and we proceeded for some mutational analysis like JAK2 testing. Here BCR-ABL was negative. JAK2 was positive. So here the diagnosis of myelofibrosis was established. Now myelofibrosis can be primary or secondary to any other bone marrow disorder. Next slide.
Hello, madam.
Next. Next. So here the major and minor criteria were seen, and the diagnosis of primary myelofibrosis was established because there was absence of any other bone marrow disorder leading to secondary myelofibrosis. Next slide. Next. So here it is the goals of treatment of the primary myelofibrosis is delaying the progression of fibrosis, improving the symptoms, and improving the quality of life. Next slide. So the treatment of myelofibrosis associated anemia is androgens, steroids, these growth factors like erythropoietin. Others are danazol, thalidomide, or lenalidomide. Treatment of myelofibrosis associated splenomegaly is hydroxyurea, thalidomide, and now we have newer agents like JAK2 inhibitors like ruxolitinib. And finally, in high-risk disease or intermediate 2 disease, we have allogenic stem cell transplant and splenectomy in few selected cases. Next slide. Fourth case is a case of a 57-year-old male who presented with fatigue and lightheadedness, and he complained of pruritus. Next slide. His hemoglobin was high, it was 19.2, hematocrit was 60%, and serum erythropoietin level was low. His abdominal ultrasound revealed normal spleen. Next slide. So here we have a provisional diagnosis or a working diagnosis which is pointing towards polycythemia vera. So we did the JAK2 mutation, which was positive. Next slide. Next slide. So here WHO criteria of polycythemia vera: hemoglobin more than 16.5% for males, more than 16 for females, hematocrit of more than 49% for males and 48% for females, and increased red cell mass, presence of JAK2 mutation, and bone marrow will show hypercellularity with trilineage myeloproliferation, and serum erythropoietin will be subnormal. It's a minor criteria. Next slide. Final diagnosis was polycythemia vera. Next slide. So for initial treatment is phlebotomy or low dose aspirin, and in some cases hydroxyurea, or in the past interferon alpha used to be used, and nowadays the treatment involves ruxolitinib. So here in very elderly patients, intermittent doses of busulfan may be considered. Next slide. Fifth case is case of 34-year-old female who presented with to emergency department with generalized pain and fatigue. She had backache, which was non-specific, and she had episode of hematuria. She had an episode of hematuria and epistaxis, but these bleeding episodes were self-limited. Next slide. Her hemoglobin was normal. Her WBC count was also normal, and but only thing is her platelet count was 45,000. Next slide. Her PT, PTT were normal. So here we are thinking about ITP. Next slide. Next slide. So we did her peripheral smear, which showed thrombocytopenia. Platelet size were normal or slightly larger. RBC were normal. WBC were normal. Next slide. So ITP is a diagnosis of exclusion. When we rule out other platelet disorders, then we arrive to the diagnosis of ITP. Next slide. So here they present with bleeding manifestation or bruises. They have low platelet counts, and then after ruling out other causes of low platelet count like dengue, malaria, and other disorders, then we come to the diagnosis of ITP. Next slide. So here the treatment mainly involves, if they are if it is mild ITP, sometimes we can only observe. Otherwise, we treat them with steroids or IVIG. Subsequent treatments in ITP may involve rituximab. Other treatments are splenectomy, and nowadays we have L-Trombopac. And special considerations for secondary ITP, the diseases like HIV, HCV, and H. pylori may be associated with secondary ITP, where the treatment of the disease is important for controlling the ITP. Next slide. Platelet transfusions hardly have any role in ITP. Sixth case is a case of a 25-year-old female who presented with bruising, history of bruises. Next slide. So here her platelet count was 12,000, hemoglobin was 11, WBC was 1,900. Next slide. Next slide. Her bone marrow was hypocellular, and bone marrow was aparticulate and hypocellular, and marrow showed absence of any hematopoietic elements. So here she had pancytopenia like picture, low platelet count, less RBCs, and low WBC count. So here we ruled out megaloblastic anemia by doing the B12 folate levels. We ruled out ETP because there were no schistocytes. And next slide. So here the things were pointing out towards the severe aplastic anemia because the marrow cellularity was low, neutrophil count was low, platelet was low, retic count was low. Next slide. So severe aplastic anemia will have low levels of platelet, less than 20,000, low levels of retic count. Next slide. So how to treat severe aplastic anemia? If it is less than young patient, less than 35-year-old, they should be treated with horse ATG and cyclosporin. Others are treated with other treatment options are stem cell transplant. In refractory cases, again stem cell transplant, LOBMT, L-Trombopac, and ATG and cyclosporin A. Next slide. Last case is a case of a 66-year-old male with poor general condition. He had fatigue, continuous fever, night sweating, weight loss. Next slide. He had pallor and no lymph node or spleen or liver enlargement. His hemoglobin was 7.4. His WBC count was 2.1. Platelet count was also low. Next slide. So only 1% blasts, pancytopenia, and elevated serum LDH on the biochemistry. So here there is a multilineage dysplasia with 5% and bone marrow. In bone marrow, there was multilineage dysplasia. There was 5% blast without or rods. Next slide. So here it is all pointing towards myelodysplasia, and he was diagnosed with myelodysplastic syndromes due to presence of cytopenias, few blasts, and multilineage dysplasia. Next slide. Next slide. Next. 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 So treatment of MDS, it involves the symptomatic treatment in the form of blood transfusions with iron chelation, growth factors like GCSF and erythropoietin. Lenalidomide can be used in some patients of MDS, and the treatment of high risk and intermediate risk cases involves drugs like azacitidine, and AML like chemotherapy may be needed in some treatments of MDS. And in some selected cases, we do allogenic stem cell transplant. Next slide. Yeah, we'll skip the next 3 slides. Next. 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 Next, please. Yeah. So to summarize today's my talk, so when there are few blasts and the splenomegaly and a normal looking patient, we can do the tests of CML, particularly PH chromosome. Philadelphia chromosome is the hallmark of CML. And if the blood tests are having features like more than 20% blasts, then and myeloid markers positive, then it is pointing towards AML. Third thing is when there are constitutional symptoms, splenomegaly, and in the bone marrow there is fibrosis, then we should go look for primary myelofibrosis. In patients who have elevated hemoglobin and hematocrit and low erythropoietin level, we should look for polycythemia vera. Next slide. So in patients with cytopenia, pancytopenia, when the bone marrow is hypercellular and with few myeloblasts, we should think about myelodysplastic syndrome, particularly in elderly population. But nowadays, myelodysplastic syndromes can also be increasingly being seen in middle-aged people also, or young people also. Presence of bleeding manifestation like purpura, first we need to rule out infections and other causes, and before arriving to diagnosis of ITP, it is a diagnosis of exclusion. Other thing is if there is pancytopenia and low platelet, low retic, then we should think about severe aplastic anemia. And there is a disorder called as advanced systemic mastocytosis, in which there are cell proliferation and bone marrow biopsies needed to confirm, and the blood in there we have elevated tryptase levels. So these were some of the key diagnostic features few hematologic disorders. Here I conclude my talk. Thank you for the patient hearing. Thank you.
Excellent talk.
Thank you, ma'am.
Yeah, thank you so much, madam.
We get to learn many things from this. There are many things in the CBC, and actually I had talked with her, and she told that it is good to highlight, and she mainly highlighted on all blood cancers and how to diagnose and treat. That was very nice of her. And I think we should go for question and answer session. Speakers are waiting since long, and we are already late, but we'll try to cover most of the questions as early as possible. So I request everybody to be a little brief in their talk, and I request our MOCs to take over the question.
Hello, sir. There is a question. Few questions are answered, so few questions are open. So we have taken the open question first. So is it necessary to thaw the FFP in water? A question for the panelist. When the FFP is ordered in the hospital, we are thawing it. So is it necessary or mandatory to thaw it in water, or just keep it like that?
Is anybody taking the question? What?
Thawing, is it mandatory to do in water or directly?
I don't know whether
for as regards information, what I have a blood bank, that FFP is a frozen plasma which is hard and it is ice, and the thawing is done in the blood bank itself, and that is liquefied and it is given. So nothing to do in hospital. They just have to transfuse. This is what I feel so.
Okay. Thank you, sir. Thank you, Rajendra sir. Do you need Ashwini, please?
So sorry to interrupt you. I'm so sorry. Next question is: should you routinely give antihistamine before blood transfusion? Should you?
Never.
It was answered many times, but madam will answer once more.
No, never. You should not give unnecessarily any medication, no steroid, no antihistaminics, no nothing before the transfusion, no Lasix, except where you have the cardiopulmonary compromise and you are finding impending cardiac failure, you may consider Lasix. But only after an allergic reaction starts, then only we give antihistamine.
Yeah, are you asking?
Yeah.
In case of large volume transfusions, is there any formula for how many FFP units and the packed cells should be given or transfused?
Madam Mamta, madam.
Mamta, madam, it's question for you.
So I really wouldn't be able to tell you for adults, but for children, we generally wouldn't transfuse more than 10 ml per kg body weight of packed cells or plasma at a given time. And if there is a need to give ongoing, we'll have to keep evaluating the need and keep giving accordingly. So that is how we would give.
I would agree with Madam. So for FFP or fresh frozen plasma, 10 to 15 ml per kilo for kids. For adults, usually what they would practice is that these are available as small packs. So for an adult patient, you tend to use between 2 to 4 packs at a time. Evaluate again and see whether more is needed and order more.
Thank you, sir.
Yeah, thank you, sir. And for autologous blood transfusion, we have many questions actually. How can we do autologous transfusion? Anesthetist with lethal for autologous transfusion. How many days prior the blood should be collected? What is the cutoff HB levels?
Is Ruhi in the panel? Ruhi would be well placed to answer this.
Yeah.
She's in our blood bank. Will you speak up?
Or even Dr. Rajendra Chauhan can answer it.
But basically,
Yeah, for autologous, I'm sorry, sir, if you want to go ahead, you can.
Yes, please.
No, Rui is there.
For autologous, usually the hemoglobin cutoff which is kept is at 11 grams per deciliter. That comes to around 33% of the hematocrit. And we aim, there are actually 4 types of autologous transfusions, like it can be collected freely in the blood bank, and that should be collected at least 72 hours prior to the procedure which is being planned. Other one can be the intraoperative hemodilution, where the blood is just collected in the OT, stored there only, and then transfused back to the patient. And the other 2 are the post-operative salvage through the venous size or after the patient comes out from the OT, which are comparatively lesser used. So the cutoff is 11 and the time gap is 72 hours, which is routinely followed.
Nice answer. Yeah. Next question.
Can you throw light on the cord blood storage at the time of delivery? Is it really helpful? And the same question is asked by another delegate also. There is a lot of plethora of people or agencies who are coming for cord blood collection, and a lot of money spinning is there. So is it really helpful, and that volume collected, is it really sufficient if the adult child becomes adult and later on there is a need for that cells?
So if I may be permitted, because this is something very close to me,
yes,
I'd love to answer this. Yeah.
Yes, ma'am.
So first of all, cord blood banking, private cord blood banking has hardly any role in the life of the patient or person. Public cord blood banking should be encouraged, because sometimes we can use these cord bloods for transplants in matched unrelated transplants. As a top-up, you can use cord blood banking, cord blood stem cells. But today, cord stem cells are hardly being used except in certain situations. But as for use for the same person or the baby who is being born, it has hardly a role, because most of the times you need stem cell transplants in genetic disorders. And if it is a genetic disorder, you can't use the same baby's cord stem cells. Secondly, utilization of these cord stem cells for some other condition in this baby in the future, that chance is very little, 1 in a million chance that you may require it. Thirdly, if you're going to use these cord stem cells beyond 15 to 20 years of banking, there is hardly an evidence whether this would have good viability. So there are many queries, and therefore public cord blood banking should be encouraged. Private cord blood banking should be discouraged. This is my final conclusion.
I agree completely with Madam. I see less and less use for these public cord banks actually. And as a transplanter, to be honest, I think I showed the graph where cord cells are being used less and less, but that's not to say there is not a definite area where they can be used. And that's where a good public cord bank can come in. But for a young mother, young parents having their first child, and if they're being pressured to preserve that cord cells, it's an absolute emphatic no, you do not need to do that.
Yeah, this is cleared many of the confusion in hundreds of thousands of gynecologists' mind, because we are always there what to do and what not to do. We want to help the society well to do, and this is the clear-cut decision what we can now take. Thank you very much, Mamta and Santana. Thank you, Madam. Mamta, madam. The next question, please.
Thank you so much. Next question is, in case of large volume transfusion, is there any formula of how many FFP units per packed cell unit should be transfused?
How many?
How many FFP units per packed cell?
Same. So it's the same question that they are asking again.
Same question repeated.
Yeah.
On grossly, what we do is out of 2 pints, at least 1 FFP we give.
Yeah.
Grossly.
Yeah. Yeah. Because it should be 1/3 of the volume.
Yes, yes.
Packed cells should be about 1/3 of the volume, roughly.
Thank you. Next question, Rajendra. Rajendra. Okay.
I think he's answering a call.
They are asking for leukodepletion, what we do in blood bank. Is that done for all the child and all the blood? Can it not be done for all the blood transfusion rather than only for thalassemia child? What is the answer, madam?
So when you are doing multiple transfusions, it is much more advantageous. But it is advantageous for even a single transfusion. But in India, we have to look at the cost versus benefit, and especially in public sector where I am working. Therefore, we would insist that you do it at least for those who are requiring multiple transfusions. But ideally, yes, all blood should be leukofiltered, all packed cells rather, all packed red cells should be leukofiltered ideally.
I can agree with that. And I think Ruhi will back me up on this. I think in our own blood bank, each and every donation that takes place is actually leukofiltered at source itself. So we don't use filters at the bedside. They are all done at the blood bank. And ideally, that should be the best possible practice.
Yes, absolutely true. That is the best practice to be followed, that the leukoreduction is done at the point of collection itself. So as ma'am had shown correctly, that no release of cytokines or WBC disintegrated products are there in the stored blood, which will not cause any problem at the time of the transfusion to the recipient. The cost being a constraint in India, that is an issue, but definitely that is the way forward, and we should aim towards having 100% leukoreduction for all our patients.
Let me remind everybody that bone marrow transfusion, which is done at comprehensive, and other setups are done free of cost, but it costs lakhs of rupees, I think. Right, Mamta madam, can you throw light on how much cost it may be at your place?
So of course I have Shantanu with me, so he can throw light on the cost in his corporate hospital. But as we know, at Sion Hospital, we have a 1-bedded unit. And we have 8-bedded unit at the Borivali Center where I am right now. And we do at no cost or nominal cost to the patient. By that, I mean, if a patient is below poverty line, it is done free of cost. Of course, there is constraint of wait list now. In the initial days, we were inviting people to send their patients, but now we are a little wary because we have to refuse to them because there's a 4 to 6 month waiting list already. So those who are elective transplants can be definitely, fitted in with a waiting period. But those who are emergency transplants are difficult to, because we have to refuse them and send them to other places. Of course, patients who are affording may contribute sometimes 50,000, sometimes 1 lakh. But in private sector, generally on an average, a matched sibling donor transplant costs about 20 lakhs. This is my understanding. And it can go up to 40 to 50 lakhs if it is a haplo with manipulation of stem cells, etc. And depending on the complications that occur post-transplant, the cost can escalate. I am sure Shantanu doesn't want to discuss too many details, but a fair idea. You can give a rough idea of how much it can.
So I'll divide the cost into 3 types of transplants. You have autologous transplants where the patient's own stem cells are used. Then you have allogenic, where a family's sibling or a parent or a family member is 100% matched. Third is an unrelated donor, and fourth haplo. So if you look at the least cost, it will probably be an autologous, which is used in adults for multiple myeloma and other conditions. So depending upon the center, the cost of an autologous transplant is anywhere between 8 to 12. However, it depends, as Madam said, upon complications. And we have done transplants even in the adults for as low as 6. But then again, if you have complications, ICU stay antibiotics, it can go higher. So peg it at about 8 to 10 for an autologous. When we do a matched sibling donor transplant, the cost is higher. It's somewhere between 15 to 20 is the average cost of a transplant. Going one step higher, when we are looking at doing an unrelated donor transplant, where we have to obtain the stem cells from one of the registries, the registries charge somewhere between 8 to 10, some a little bit higher, but let's take an average of 10 lakhs for actually procuring and giving the stem cells to the transplant center. You got to add the transplant cost and allogenic cost to that. So you can see it easily goes to about roughly 25 to 30 when you're having an unrelated donor transplant. A haploidentical, where we do a half match donor transplant, again, costs approximately the same, roughly between 20 to 25 lakhs for a haploidentical. And as Madam said, sometimes if there is manipulation, where is this thing called TCR alpha beta depletion, which is to lose that, if those things are done, that adds another 10 lakhs. Now, sounds really expensive. However, like Madam said, there's help available. So in our center as well, our thalassemia transplants, if they are matched sibling, we do them free of cost. That's a partnership with NGOs, with Coal India Ministry of Health and Family Welfare. But for other patients as well, nowadays we have access to crowdfunding for all our patients. And almost each and every patient that we've transplanted, we've managed to offset a huge chunk of their cost, a vast majority of their cost, by going into philanthropic organizations with help with the cost. And there's a very few who need to bear the full cost. So message out to my colleagues and to patients is that there is help, and we can always access various help from various organizations to kind of provide a cure to our patients.
Thank you very much.
I would also like to just add up one more point, is that though I am saying at no cost or nominal cost to the patient, but money is involved, we need to spend money, and that money comes from NGOs and trusts and other places, government funding, etc. So Shantanu is right. Even in their hospital, Coal India is now funding the thalassemia transplants completely, or to the tune of 10 lakhs or so. And I think for a plastic also. So I think there is now hope and help available for all patients who desire a transplant and deserve a transplant.
Thank you, madam. Thank you very much. Next question, please.
Sir, unmute. Rajendra, sir, unmute.
Unmute kara.
Tiwari, sir, unmute.
Yeah.
Hello. Dr. Manglani, madam, your center's address and phone number, one delegate was asking.
We can, no problem. They can Google us. We have a website now. So he can Google on www.ctcphobmt.com.
CPC.
CTC, Comprehensive Thalassemia Care, as in CTC. ctcphobmt.com. So you can get the all the
details,
contact numbers as well as the address, all details.
It's in Borivali. And
Borivali East. Yeah.
Just put thalassemia and this all Google is full with madam.
Yeah, it will come up on Google. We are not as popular as Ambani's and Reliance and others, but we are there now somewhere.
Madam, I have to say this. I was going to say it anyway, but you took the words away. But if any of you have not been to Madam's Center, please go and visit it. And it will change your concept of what a government center is. It is as good as anything you might find anywhere in the world. It's spacious. Everything is done absolutely properly. It's a world-class institute. It's something that I think in Bombay we should be proud of.
Thank you, Shantanu, for those lovely words.
Just superb.
Question is how to diagnose and manage thalassemia patients.
So I think we need to have one more lecture because it's a full subject. But in short, if I were to say, first of all, how we differentiate between a transfusion dependent and a non-transfusion dependent thalassemia. There are TIF guidelines wherein you look at the drop in hemoglobin below 7 gram%. If a patient comes to us first time and he is not below 7, or even now he is below 7, but a second repeat drop in below 7 doesn't happen at least 2 weeks apart without any other reason for a drop, then you need to consider non-transfusion thalassemia, non-transfusion dependent. But in case the hemoglobin is not dropping below 7, but the patient has certain clinical features such as fractures, growth failure, hepatosplenomegaly, any extramedullary hematopoiesis. These are the patients who need to go on transfusions and cannot be labeled as NTDT. So treatment-wise, there is a lot of difference in managing. Hydroxyurea is one of the wonderful drugs we try in all patients who are NTDTs. If they do not manage to come up with that, now we are looking at alternative newer drugs also. And their management is totally different. Their monitoring is different. Their iron overload doesn't happen very soon in life. But once it happens, you have to start them on chelation, by and large, after 10 years of life. So all these aspects are very different.
And some of them actually change over time. Basically, as Madam says,
Yeah.
they might become very transfusion dependent sometime, even at 5 years or 8 years, they suddenly develop a need for regular transfusions.
Hello, Dr. Sen, sir, there is a question for you from delegate. Can an autologous transfusion be done in AML cases while in the case of remission and all?
No, I would not do it. I mean, by its very nature, it's a malignant disease. So which means that malignant clone would still be there in the bone marrow. So even if the patient is in remission, there's no guarantee that a clone of those cancer cells, that myeloid cells, is still not there. So for an AML, it has to be an allogenic transplant. We need to find a different donor.
Thank you, sir.
So I think the concept of autologous transplant, I'm sure Santanu will bear me out on this, is for solid tumors where you want to give very intensive chemotherapy. And when you give intensive chemotherapy, you want to guard the patient from suffering from the hematopoietic system getting totally crashed. And therefore, you want to replenish him with his own cells from the bone marrow or the peripheral blood stem cells, and make him sufficient for managing over a period of maybe 20 days. So he will suffer the neutropenia and thrombocytopenia as well as anemia only for a period of 20 days at best, and he would recover. So that is the basic principle of autologous transplant for malignancies. You cannot do autologous in a marrow disease because you never know whether microscopic or even microscopic, I would say, what we call as MRD, the minimal residual disease, is still lurking in the marrow. Even if MRD is negative, there could be clones, as rightly Shantanu said. And therefore, when they are in remission, generally, we try to push them with harsh intensive chemotherapy and do a allogenic transplant with a donor who's a matched sibling donor or any other donor, as we have discussed.
Absolutely. Absolutely.
Thank you, ma'am.
Question is BMT is helpful in chronic sickle cell crisis patient and chances of relapse after BMT in sickle cell patient?
So sickle cell is a very interesting disease because in sickle cell, the phenotype and genotype are completely different. So in a family, you might have two patients with sickle cell disease, so that the genotype is the same, but one of them might have a very, very severe phenotype needing regular transfusions, hospital visits, the other will be completely normal. So any patient who is suffering from sickle cell, and there are now very definite criteria to say who should be transplanted, and they have now become more liberal. Because whereas previously the criteria was that you need to be almost like on the point of dying from a stroke or a major neurological insult before you be transplanted, now it's become very practical that if your quality of life basically is hampered by your disease, you need a transplant. So yes, he can be. The second very interesting thing about sickle transplants, and I've done a few, is that unlike thalassemia, and Madam would know this, then thalassemic patients, you really need a really high donor chimerism. So which means your patients, in your patient, the percentage of donor cells has to be quite high, 90 plus. We know that if ever the chimerism drops below 95, goes to 92 or 90, that most of those transplants would fail and those patients will go back to needing blood transfusions. With sickle is wonderful because even if you have a chimerism of 60 or 50%, or even I've got one of my patients whose chimerism is 35%. So if that patient was thalassemic, that would be failure. But with sicklers, even with that little bit of donor cells still persisting, they have a complication-free life. So most of them will not have any painful crisis. They will not have any of the other coincident problems that's happened. So I'm kind of like a huge, huge supporter to say that if you have a bad sickler who is suffering, that's the patient that needs a transplant immediately.
Thank you, sir.
Any other question? Rajendra?
There is who can become. There is one question, sir. Can the panel elaborate on the process of being on bone marrow registry and actual process involved in that when one is identified as a match?
Okay. If I take that question, so actually nowadays it's become really simple. So the possibly the two big registries in India today are Datri and DKMS, and both of these organizations, they run various stem cell voluntary donor camps at various places, schools, colleges, army camps, and we've been part of them for many years. But also anybody can become a donor. So if you just go onto their website, and which is Datri and DKMS, you'll find a tab that say, I want to be a donor, which means when you put in your details there, they'll send you one small packet with a little swab in it. So you take that swab, it's a cheek swab. You just take your cheek cells, put it in an envelope and send it back to the registry. What they do, they isolate the DNA and do an HLA typing on that. And that HLA typing result gets stored on their computers. That's it. So there's no blood test involved, nothing else. Simple cheek swab, it goes off and it gets sent there. At some point in the future, if at any transplant center in India across the world, somebody accesses that database and finds that their patient is completely matched to the donor, that's when the donor gets contacted and asked, and his permission is sought and asked whether he would like to be a donor. So I alluded to this briefly in my presentation that whereas outside, any individual outside India takes it as a badge of honor to say that I can save a life. My practical experience with my Indian fellow countrymen has been that more often than not, there's a lot of misinformation and a lot of myths about that, about being a donor. And many family members themselves would, once they hear that a young college going kid wants to be a stem cell donor, they all gang up and say, oh, aap aisa kyun kar rahe ho? Future barbad kar rahe ho, mat karo. So my colleagues at the registry need to do a lot of education to actually persuade them that they should do it. But if all goes well and they are persuaded and we know that we have a donor, then the donor stem cells are collected and they are lifted back to us to the stem cell registry. So briefly, that's how it happens.
Thank you, sir.
Just one point I'll add to Shantanu's, what he alluded upon stem cell donor. I feel that the fears are unfounded. And today we do mostly peripheral stem cell collection from donors. And that is a procedure like a platelet donation, similar. I mean, you go onto the apheresis machine, here it takes about 4 to 6 hours to collect them. But there is no bone marrow harvesting done by and large. Very few donors today will undergo bone marrow harvesting, which is done under general anesthesia and has some risks at least. So we should dispel this myth amongst people who want to become donors that most probably you will not have to undergo anesthesia. 90% of the times you will not undergo any anesthesia and you will be just put on the apheresis machine to collect the peripheral blood stem cells. Then they might get encouraged. I think we need to do a little more of awareness campaigns about stem cell registry and becoming a donor, because huge young population in India, but we have hardly any donors. As rightly Shantanu said, about 4 to 5 lakh, that too after struggling for last almost 15 years, we have got to this number. So all of you, please, I'm pleading to you and appealing, encourage more people to become stem cell donors as much as blood donors are required.
Yeah, thank you. Very nice.
Thank you, ma'am. Thank you.
One question comes to my mind. This is especially for Seema Jigyasi, maybe the last question or one we may take. Is Seema madam there? That she could diagnose the different cases of in blood disorder. So is there any ready reckoner app or something where we just put the slide and then we get, or some auto intelligence where we can immediately get diagnosis, like how ECG is done, and then that gives the diagnosis? Is there anything like that?
No, not yet.
Not
we
yet.
need clinicians.
We need hepatologists. Don't take our job away.
Yeah, we will get substituted if you have such an ad.
Okay, any more question or should we cover up? I think there are many small questions, but major of the thing we have asked,
they have been answered also.
I have got the opportunity to thank all, and it is really my proud privilege that such a elite speakers And I really, from core of my heart, I want to thank Mamta Madam and Santanu and Seema Jigyasi and many other, all the Alok and whatever name I have forgot, them and both my MOCs, Dr. Rajendra and Ashwini Kalyankar. That the program was done by you all and it was excellent, far excellent. There is after a long time I could see such, and I am very much satisfied with this. But along with that, I should really thank my president who has given us the opportunity, Dr. Nirima Bhamre Madam. Along with that, Dr. Hemant Duggad, secretary, always supporting me for this. AMC office staff, Pramila and all office staff, I could not forget them. They were all very helpful to me. Definitely, the speakers, I have no words to thank you, and whatever message you have done, it will be propagated long. I am the social worker in my blood, so definitely I am going to take, but I am going to tell other people also to do this. Our MMC observer, Dr. Rajiv Agrawal, was there. He is all the time and he was monitoring and motivating us. So Dr. Rajiv Agrawal, we are really thankful to you also, even MMC, to give us a credit point for this, because sometimes they may think it is non-specific, but this is very much specific. So MMC also, with the president and all people, we thank all the audience who had registered, not registered, who are speaking, who have seen and who are going to support us for the society. I have, if anybody I have missed out, I really apologize for that, and I once more thank each and every person for cooperating and coordinating with us. And let us take this much ahead. We will be coordination with each other later on also. And thank you for your kind support. Dhanyawad.
Thank you.
Thank you, Dr. Chavan. Wonderful session. We too enjoyed it.
Thank you,
Thank you, ma'am.
Thank you. Thank you.
Thank you,
everybody. Yeah. Bye. Bye, Santanu.
Bye, ma'am.
Also, webinar was conducted by Pranav of Innovate. We should, I forgot to take his name. Thank you, Pranav, that you did the best of the thing, and we did not have any technical hitch. And Innovate also, thank you very much. And we can end the program, Pranav, if you are there. Or I'll call
Thank you, sir.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you, Ashwini. Thank you, madam.